Good afternoon and welcome to the annual Hela conference hosted by New York Medical College and the WMC Health Network. Our two organizations have been partnering for many years to hold this annual meaningful conference. We have decided to make this part of our celebration of Black History Month. Every year, we honor the life and legacy of Henrietta Lacks, who was a young woman with cervical cancer. Her tumor was biopsied at Johns Hopkins University Hospital in 1951, and they found that her cells were immortal in that they reproduced indefinitely under certain conditions. Her cells went on to be used for research without her consent, and after she died, they continued to be used for research. Neither she nor her family were compensated for their use. This is but one example of unethical research that has been done on marginalized communities here in the United States, and without question is one of the contributing factors to COVID-19 vaccine hesitancy in many of our communities. Over the past 2 years, we have had to work even closer between NYMC and WMC, particularly in our battle against COVID-19 and also in the battle to achieve health equity in terms of outcomes from COVID-19 infection. I worked closely with Josh Ratner, who led the Hudson Valley's Herculean effort for the vaccine distribution. And we worked arduously with community partners to make sure we identified communities that were less vaccinated and took measures to increase those vaccination rates. Some things we have done has been to educate communities, partner with local organizations, particularly looking at zip code data and the lower vaccination rates. We also stood up pop-up or satellite clinics for vaccination and also used a mobile coach to go into communities to both register people for the vaccines and administer the vaccines. This strategy that I just described, which resulted in a significant increase in our vaccination rates in the Hudson Valley, and also decreased the deaths from the COVID infections locally, is an example of tackling the social or structural determinants of health. Before we begin, I do want to thank Ms. Kelly McMillan and her team from the WMC Office of Government and Community Relations for their work in helping us plan out this year's conference. Thanks to Dulce Argalar from the DNI office at NYMC. And thanks to our wonderful AV team, particularly Michael Cotter, Michael Frankfurter, and Juan Castro, who have been doing exemplary work, especially as they have kept us going throughout the challenges posed by the pandemic. I am just, I should have from the beginning introduced myself. I'm Dr. Millie Tien, the Vice Chancellor for Diversity and Inclusion here at NYMC. I will now be introducing Dr. Halpern, who will provide some opening remarks. I'll give a brief intro. Dr. Edward Halpern is Chancellor and Chief Executive Officer of New York Medical College and Provost for Biomedical Affairs of the Touro College and University System. He is a pediatric radiation oncologist, medical historian, and health sciences educator. Under his leadership, fundraising has risen, the research program has expanded, and in recent years, the percentage of students underrepresented in medicine rose to the highest percentage in the US for a historically white majority MD program and rose to 25% in the graduate programs. Dr. Halpern previously served as Dean of the School of Medicine at University of Louisville and Chair of the Radiation Oncology Department at Duke University. He received his Bachelor's in Science degree in Economics, summa cum laude from the Wharton School of the University of Pennsylvania, his MD cum laude from Yale University, and an MA from Duke University. He completed his internship in internal medicine at Stanford University and his residency and chief residency at Harvard Medical School, Mass General Hospital. He is the co-author, editor of numerous radiation oncology textbooks and published more than 220 articles in the peer-reviewed scientific, historical, education, and ethics literature. He and his wife Sharon are the parents of 3 daughters and the grandparents of 4 grandchildren. Everyone, please welcome Dr. Halpern.
Thank you, Dr. Etienne. I guess it's an old biography. I'm up to 5 grandchildren, another measure of how old I am, I suppose. Good afternoon, everyone. I'm delighted to be able to join you this afternoon. And as Mill says, my name's Edward Halpern. I divide my time between chancelloring, being a pediatric radiation oncologist, and working in the history of racial, religious, and gender discrimination in medicine, medical education, and medical care. I have no conflicts of interest to declare in reference to my few minutes of remarks this afternoon. It is in February, Black History Month, and in March, Women's History Month. Entering in the New York Medical College class of 1869 is the woman on the left of my slide, Susan Smith. And on the right side of my slide, decades later, there she is again, holding her head in a very similar fashion, cradled in her right arm. By this point, she is Susan Smith McKinney Stewart. And this is her husband, Theophilus Stewart, an officer in the United States Army. In a message to the campus last week, I told the life story of Susan Smith McKinney Stewart and Theophilus Stewart. But this afternoon, there's something on my mind quite different I'd like to talk with you about for a few minutes. And it is the concept of intentionality and the Tuskegee study of untreated syphilis. I have not had the privilege of having an advanced preview of Dr. John's remarks, but I see by his title that I suspect he and I are both going to be talking about the concept of intentionality. What were people thinking? When were they thinking it? And how would you understand their thinking in the context of their times? The Tuskegee study of untreated syphilis was launched in 1932. Participants included the nurse Eunice Rivers in the upper left-hand corner, the physician-in-chief at the John Andrew Hospital in Tuskegee, Eugene Dibble, and officers of the United States Public Health Service. This study is well known to many of you as a study intended to observe the natural history of syphilis. In 1907, the Nobel laureate Paul Ehrlich receives the Nobel Prize for his work on the so-called magic bullet. Ehrlich and his collaborator Hatta have had success in work on diphtheria with Emil von Behring, and they turn their attention to the chemotherapy of syphilis. On their 606th try, they come upon compound 606, arsorfenamine, which is brand named Salvarsan by the Bayer Pharmaceutical Company. This arsenical compound must be prepared with the kit, which I portray on the right side of the slide. It is reasonably effective against the early and middle stages of syphilis. It is ineffective against late stage syphilis. It is very difficult to prepare for human administration. It has serious side effects. It is far from a magic bullet. Also in 1932, there is a serious debate in medicine about whether syphilis, like malaria and yellow fever, has different attack rates or different clinical outcomes as a function of race. Now, understanding that we're talking about events of 90 years ago, but we're striving to understand people in the context of their time. Also, at the time the study began in 1932, our understanding of informed consent for medical experimentation was very different than it was 20 years later, because in 1946 and 1947, the Allied powers put 25 physicians and hospital administrators on trial for crimes against humanity, including failure to obtain consent for alleged medical experimentation. But the judges realized there is no legal code requiring informed consent, and they write one. We now call that the Nurember Code of Medical Ethics, and it develops the legal standard of informed consent from the patient to participate in a medical experiment. What's on my mind this afternoon is that 2 weeks ago, an editor of a medical journal asked me for help. The editor told me that a professor had submitted a manuscript to his journal, which asserted that the Tuskegee study of untreated syphilis must now be reinterpreted by historians because the historian asserted the patients were told they had syphilis, because they were told they had, quote, bad blood, which in the context of its time meant they had syphilis and nothing else. Furthermore, this person submitting the manuscript provided evidence that some of the so-called untreated men in the control arm did get penicillin when penicillin became available after World War II. The editor wanted to know what I made of this manuscript. Well, I wondered whether these assertions stood up to scrutiny. First of all, I'm old. And I'm old enough to remember when we would tell patients they had high blood, which might have meant hypertension or polycythemia or leukemia or anxiety, or when we used to tell patients they had low blood, which might have meant anemia or leukopenia or thrombocytopenia or hypertension, or when we told patients they had bad blood, which might have meant sepsis or hyperglycemia or venereal disease or electrolyte imbalance. I am therefore old enough to reject the proposition that telling people in 1932 they had bad blood meant syphilis and nothing else. It was a euphemism which were used in a wide variety of diseases and does not strike me as informed consent. More importantly, it has been known for over 60 years that some of the Tuskegee study of untreated syphilis patients in the so-called observation arm did receive curative doses of penicillin when penicillin became available, starting in the 1950s. Which leads me to the issue of intentionality, which is what were people thinking at the time, in the context of their times, what were their intentions? And I believe the key question in this issue related to diversity and inclusion in medicine is that of intentionality. 1932 was very different than, say, 20 years later, 1952, because by 1952, we did have standards of informed consent, and they had been promulgated, and we did have penicillin, which was both available and known to be curative and far different than Salvarsan. So, to me, the arguments that the medical editor was grappling with reminded me from the book of Genesis, chapter 16. Remember when Abraham argues with God over the fate of Sodom and Gomorrah? Will you destroy the cities if there are 100 righteous people? What about 50? What about 10? What about 1? In my view, when it comes to judging behavior, intention matters. And whether 1, 2, or 10 of the 74 survivors in the untreated arm of the TSUS had received curative therapy by the time the study was closed in 1972, in my view, once modern standards of treatment and consent were in place by the late 1940s and early 1950s, there was no remaining defense for the study. The intention of the study was immoral. And whether a historian says that 1, 2, or 5 patients got penicillin does not change the intent in the context of the availability of knowledge about informed consent and penicillin. An unsung hero of the story is this man, who I bet you've never seen. His name was Erwin Schatz. He graduated from the Chicago Medical School, and 4 years after he graduated from medical school, he read an article in the Annals of Internal Medicine about the TSUS, and he wrote a letter to the United States Public Health Service in around 1956. And he said, I understand what happened when the study was opened in 1932, but now we have penicillin, and now we know what informed consent means. This study is immoral and needs to be stopped. Archival records show that Dr. Schatz's very brave letter for someone 4 years out of medical school was filed with a note saying, do not answer him, and was only uncovered by an investigative reporter from the Wall Street Journal about 30 years later, when Dr. Schatz was congratulated for his brave stance. In 1972, the New York Times broke the story on the front page, but I call your attention to the first paragraph. For 40 years, the U.S. Public Health Service has conducted a study in which human beings with syphilis who were induced to serve as guinea pigs have gone without medical treatment for the disease, and a few have died of its late effects even though an effective therapy was eventually discovered. That, I think, is the key issue of what I wanted to share with you this afternoon. When it was discovered, the study was unequivocally immoral. The patient should have received penicillin, and no historian now saying I can identify one or two more patients who did get penicillin, in my mind, changes that. Dr. Aitan, thank you for inviting me to say a few words this morning. And if there are any questions or comments, I'm happy to receive them. Otherwise, I'm happy to listen to my colleagues this afternoon.
Thank you, Dr. Halpern, for that wonderful history lesson and reminder about the events of that experiment, and also just providing some new information. It's always interesting that with history, going back, you can always find out more and learn more, and additional analysis could always be indicated. I can take a quick look and see if there's any Q&A. Otherwise, I don't see any open questions. Okay. We'll take one question and then we're going to move. It says, if they were not aware of informed consent and human experiments, why would they not include white people in the experiment?
Well, there's two answers. Thank you for the question. First of all, because it was blatantly racist. That's why. It's because they were doing what medicine often does, which is to decide that it's okay to do research on the poor, the Black, and the marginalized in society, but not on people in positions of power. It is why American medicine has a sorry history of medical experimentation on prisoners, on members of the Navy and on the Army, and on people who cannot push back. That's the first answer. The second answer is that in Macon County, Alabama, there were some very serious and sober infectious disease people writing papers saying, tertiary syphilis does not look as debilitating to me as it has been reported in medical journals. And as I was taught, is it possible that something different is going on as we learned with yellow fever and malaria? Would that be appropriate to study? And that is why some Black physicians thought it was a valid scientific question. I don't think that excuses it, but I'm simply trying to explain what some people were writing in 1932. I think the first answer that I gave, that it was blatantly racist, is the fundamental answer.
Thank you, Dr. Halpern. As you all know, we are offering 3 CME credits for this conference this afternoon. You see there, you can use that QR code, or you can send a text message to the number you see there, 828-295-1144, or go to the www.eads.com and use this QR code. And you will get up to 3 CME credits based on which talks you are in on. All right. I think Dr. Halpern's talk is a nice segue to our next speaker. I'm going to be introducing now Dr. Tracy Gardner. Dr. Gardner made history as the first woman and first African-American to become the chief medical officer at Children's Village in the agency's 170-year history. Dr. Gardner is also the first woman and African-American to hold her other current positions as the Director of Community Engagement at New York Medical College and Medical Director for the Greenberg 11 Union Free School District in Dobbs Ferry. Dr. Gardner graduated from Mount Holyoke College with a bachelor's degree in biological sciences and NYMC with a doctorate in medicine. She is also a fellow of the Center for Juvenile Justice Reform, part of Georgetown University's McCourt School of Public Policy, secondary to completion of supporting the well-being of LGBTQ youth certification program. She has numerous publications on topics in medicine, health, and trauma, and has been a contributing writer for the website Fit, Live, Win. Her most recent article was published in Psychology Today on the collective trauma of the Black community in 2020. What are the implications for COVID-19 vaccines? In her role as the Director of Community Engagement, she has partnered with an NAACP as well as other community organizations on topics that impact health disparities in the African-American community. She has written curriculum for the NYMC School of Medicine on patient-centered collaborative care, focused on case coordination, population health, social determinants of health, and cultural competency, implicit bias. Dr. Gardner has numerous presentations on trauma, ACEs, cultural competency, implicit bias, COVID-19. She was one of 16 people selected in the 2021 Westchester Magazine's Healthcare Heroes for the COVID-19 policy and implementation. She's been numerous times, has been on the radio, has been on television. I remember one night I was watching TV on Thanksgiving weekend and I saw her here. I said, oh, wow, okay. So she's really out there doing exemplary work, lots of recognition, including for her work with the victims from the Haiti earthquake, 2013 NAACP Image Award, among many others. And she's actually served on the United States Senate Finance Committees to address topics of psychotropic medications and child welfare. So without further ado, everyone, please join me in welcoming Dr. Tracy Gardner, one of our alumni here from NYMC.
Thank you so much, Dr. Etienne. Appreciate you as always. So I think Dr. Halpern really did, in fact, lead us sort of into this segue of the origins of inequity in medicine. So I'm going to sort of take you on a journey of history, because I think in order to sort of figure out and to have conversations around not just health inequity, but also the feelings that Brown and Black people have around our health system, we sort of have to understand how we got here. And so that's sort of what my talk will focus on today. Just like everyone else, I have a disclosure. I have no financial disclosures or conflicts of interest with the presented material in this presentation. So again, the objective, and of course, Tuskegee is the most famous study, but we'll be talking about much more than that, though there's a little bit of that in there. My objective is to discuss the documented data. As you know, or you may not know, a lot of our history, especially around medicine, was in medical journals. They documented in their records. Although there were atrocities at the time, they were considered the norm and really didn't have a problem with their thought processes around race and around health inequity. So I always say, thoughts start before deeds. So they didn't have a problem with their thoughts or deeds. So we're going to discuss the documented data that proves Black Americans have been victims of science and medical experimentation. For the purpose of this particular presentation, I am going to focus on the Americas, on America, although we know that the transatlantic passage also was through the Caribbean islands. And again, most of it will focus on the time frame of the centuries within America. The first enslaved Africans found themselves on the land of Cuba in the year of 1513, and the enslaved Africans were brought to Hispaniola in 1517. This didn't start in America, but that's will be the focus of the presentation today. And then we'll do a timeline of American history, giving the explanation of why there is iatrophobia in the Black community, the fear of medicine, fear of physicians, and whatnot. Okay, so I think sometimes when we talk about the transatlantic passage, we don't often talk about who was on the boat, right? We see the picture of the slaves that were on the boat. We obviously know the captains or whoever was driving the boat, right? But who else was on the boat? And what we don't talk about is that there were physicians on the boat, because physicians had to determine the fitness of who was on the boat. So when the physician on the boat, the surgeon on ships, were on the boat, they would be the ones who would determine whether an enslaved African was fit for the travel and ultimately for the work that they were going to be doing. And so once they determined that person to be unfit, then they were thrown overboard. So the medicine's impact started from the inception and really started from the continent of Africa. It didn't start from later on in some when we started talking about blacks getting health care, or I mean blacks getting health physicians being called for slaves. They were part of the slave system. And because ships went everywhere, I use Alexander Falconbridge, who served as a doctor on a British slave ship, and he wrote about this in his book. So I think that's important to keep in mind when we think about where we were as physicians, as medicine. Where did we find ourselves in this process? And then there were others, right? Because you think about, we always talk about where did it start, 1619 or 1776, and the Revolutionary War started in 1776, and if anybody saw Hamilton, then it didn't start and end in 1796. Even if you didn't bother to remember to read it, if you saw the play, you know that it went on for longer than 1776, right? So, but there were people that were around during the Revolutionary War, and one of these people was named Dr. Benjamin Rush. He was an MD. He was a founding father, and he signed he was a signer of the Declaration of Independence. He was also considered an abolitionist who believed that medical freedom was as important as religious freedom, and felt that it should be written into the Declaration of Independence. And he had many titles at Penn Medical School, and he is the founder of Dickinson College. And this is a statue of Dr. Benjamin Rush, that is up, as many of the other statues around the Revolutionary War heroes. He was considered a hero. Here is a picture of him on a horse with George Washington. He held many titles. He was, during the military, he was the Surgeon General in the Continental Army. He was a friend initially and confidant of George Washington, although they eventually had some disagreements, and he sort of removed him from his post. But he was very active in the military and in politics, and obviously in health. But he also believed that Black skin was a manifestation of a type of leprosy that he called negrotude, and albinos and vitiligo-stricken white Negroes as hopeful monsters, living proof that Blacks could become healthily white. He believed Blacks themselves preferred white skin. So some of the colorism that we see and that is permeated the American culture, stemmed from those who were considered founding fathers of this, of this experiment called America. And you should know that Dr. Rush was a very prominent person, because not only did he have an impact on the health system, right? As I said, he held many titles at Penn Medical School, so he had the ability to change young minds, and not just at college level at Dickinson College, but also at Penn. He was in politics, he was in the military, and John Adams ultimately appointed him as the first treasurer of the U.S. Mint. So he also had impact in the finance and treasury department. So he had a tremendous impact in just about every system of America. And think about how we always talk about some of the inequities. We're talking about medicine in particular, but a lot of our systems are interwoven. And you can see that if somebody like him has an impact in all of them, how we start to see some of the things that we see today. Then there is the Dr. Samuel Cartwright. Dr. Samuel Cartwright was a believer of tryptomania, which was like sort of the slave runaway syndrome. And so he wrote a book he called Diseases and Peculiarities of the Negro Race. Cartwright believed that the Bible calls for the slave to be submissive to his master, and by doing so, the slave will have no desire to run away. So it's important again to realize that, we're not being told in the history, right, that doctors weren't just doctors. They weren't just taking care of sore throats and physicals and deciding whether people are fit or not, but they were writing, and incorporating into their writing was what was happening socially in America, right? That they were very much a part of race, of what we know to be some of this racism and structural racism that we currently see. And before I talk a little bit more about Dr. Cartwright, I just want to add a couple of things that happened before him. So that we all know as part of our medical journey, that in 1735, the first edition of the System Naturae designated the subspecies of Homo sapiens americanus, separating Africanus and all of those, right? And so they all seem so simple, and so like they all seem to make sense to us, and you should, separate them out, and it makes sense. But if you think about it in the context, as Dr. Halpern said, like if you think about it in the context of the time, right, you have to ask yourself why, right? Why did you feel that why is this important, right? Polygenus is the 1700s, wrote Blacks were physically inferior and were liars, malingerers, hypersexual, and indolent. We still hear that today, and that was in the 1700s. Martin published and determined that Caucasians had the largest skulls, and therefore had the largest brains. Okay, and Blacks had smaller skulls and therefore had smaller brains. And I sometimes feel like, it's sort of like once you're no longer in the matrix. And so, it's like, so now when I watch things like Bones or some other show on television, and they pick up a skull and they go, oh, this is a large skull, must be Caucasian. And I'm like, and I'm thinking to myself, is this real medicine, or is this, are we saying therefore? Do you know what I mean? And so, I sort of now think, because you can't unknow what you know. Like once you've learned it, it's hard to not look at things from a different lens. Dr. Cartwright published his paper suggesting that Blacks' physical and mental defect made it impossible for them to survive without white supervision and care. Because of his work on this paper, because of this work, he was appointed chair of the Medical Association of Louisiana to investigate Black health and physiology. And we surely don't want someone with this mindset to be now involved and be part of, or be the person in charge of investigating Black health. And yet this is what happened, because he really had the same viewpoint as what was the American viewpoint at the time. Scientists adjudged that dark skin of Africans as a biblical curse that set them aside as eternal servants. This science served as a critical, political, and legal purpose, for it provided a biological and ethical rationale for enslavement. And so again, I said I will focus primarily on America, but I just wanted to sort of let you know that like the thought processes don't start in like whatever, whoever is the narrator of the story. And so, these things have a precursor. And so Roman physician Galen, who wrote this in 160 AD, described African men as possessing oversized sexual organs and inferior intelligence. But it wasn't until the 18th century did the term race go from meaning all mankind, race of man, to biologically different types of mankind, right? So, and again, we still see this sort of language of Black men having oversized sexual organs, genitalia, and inferior intelligence, and we make jokes about that. But that these things have to come from somewhere, right? And so, and what are you implying? What's the intention to which I'm sure Dr. John will talk about? What's the intention of that at the time? A year after Abraham Lincoln's Emancipation Proclamation, anthropologist Carl Christoph Bolt provided a physiological justification for their continued abuse. He wrote in 1864 that he informed readers that the Negro stands far below his white race in terms of the acuteness of his senses. So now we start to talk about not just them as inferior beings, right? And that in using their physicality as a reason for why they're inferior, talking about it being a mental defect. And now we're not just talking about their need to be submissive, but now we're talking about things like how they sense things, how they sense pain, how they sense, even how our senses are how we utilize our senses must be different, right? And so this is how you can get to a place where, therefore, right, they may feel pain differently, which is how we can get to a Dr. Mariam Sims, right? And many people, and I always say, let's address again Dr. Mariam Sims, because we're always here talking about Dr. Mariam Sims, I feel. And this is quite the famous picture of him with his colleagues about to do, he is known, for those who don't know, but he is known as the father of gynecology, but how he got that title was the atrocities by which he experimented on the Black female enslaved. And he used crude instruments, and he did not use anesthesia or painkillers because he did not feel that they felt pain in the same way, nor did he care. So he ended up, so he is considered the father of gynecology for all of his work, but we cannot negate how he got there. And I'm sure Dr. St. Jean may speak, she may speak about that as well. And here's the thing. Dr. Mariam Sims' colleagues, and this is written, by the way, because as I said, they wrote a lot of this in medical journals, were initially the ones who held her down. However, they found that it was too gruesome and too horrible to continue to be participants in this atrocity. So he could not get his colleagues to hold the enslaved woman down anymore. So they eventually left, and then he forced the other enslaved women that he was going to experiment on to hold the other women down. So the trauma of that, of having to also now know it may happen to you, and in addition, having to watch it happen to someone who looks like you in the name of medicine, speaks to why they would, in the next generation, say, do not trust doctors, right? Because these were somebody's sisters, mothers, and grandmothers. They were not in isolation. So therefore, they would take that with them when they would then speak to their families about medicine and doctors in general, at that time. And so we have to be mindful. It's not just the intentionality and the thought process of the physician, but it's also what is the thought process of the patient as well. And again, so I bring this up. I add this slide because we're now in the 1900s, and I want to sort of talk about how we've, now we're, almost 200 years in, right? So we're almost 200 years in, as we're over 200 years in, because if you start at 1619, then we're 300 years in, and but 200 years from independence from England, so 1.5 centuries, and yet we are kidnapping Africans, Otobenga, from the Congo and putting them into the World Fair and the Bronx Zoo in 1904. And this was an article that was written because it became, so there were some people who laughed and thought it was fine, but there were others who found this to be deplorable. And ultimately, Otobenga was eventually released from being in the cages with the apes. So, and let me say this to you. These kinds of things don't just affect the oppressed, but they also affect the oppressor, right? Trauma is trauma. Like if you watch this, there's something about this that can happen, that happens to you when you see something like this. So it's important to sort of see that, it's not like, when you see people being fearful of COVID, that there's not some history here that has been going on for quite some time. And I'm not going to talk a lot about the Tuskegee study because I'm sure it might be in everybody's slide. But I do want to say, I do want to just add that two things I would like to add. One is the second slide here, the second on the right-hand side. The public service, health service physician Thomas Nero brashly insisted in 1940s that the future of the Negro lies more in research laboratories than in schools. So when diseased, he should be registered and forced to take treatment before he offers his diseased mind and body on the altar of academic and professional education. So there was a thought process at the time that, as to Dr. Halpern so eloquently stated, is that there was a thought process at the time that they did this, because they wanted to, and because they thought that they could, and that they had a thought process of racism around it. And there's some history that I think is important. So, everybody talks about sort of what happened, but I also think it's important to talk about some Tuskegee, the university. So, Booker T. Washington, the founder of Tuskegee, he was an agriculturist, right? He was very much into farmers and trade and that kind of thing. He was more of an agriculturist. But the third president, Frederick Douglass Patterson, named after Frederick Douglass, of course, he was a scientist. So he had a doctorate in veterinary medicine. He had a PhD in philosophy, and he had a master's of science. So Tuskegee had moved from this sort of agricultural place that Booker T. Washington, that we all know it to be based on Booker T. Washington, to this place that was more about science and medicine under the leadership of Frederick Douglass Patterson. He also was the one who changed it from an institute to a university and expanded all of the sciences there. So under his tutelage, he had an interest in science and looking at what was going on in the community around Tuskegee, and they saw an increase in syphilis. But due to the Great Depression, they had lost some of their funding. So when the Public Health Service said, we will continue to do this with you, that you would see why, as a scientist, that he would jump at the chance to continue this work. And it really ended up being quite the 40-year atrocity. But the other piece that we don't talk enough about also is that the families, and we won't talk about the amount because I'm sure it wasn't enough, but there was some reparations that was given. So the thought process that you cannot give reparations for some of these atrocities is not really true, because it can be done and it has been done. How do we get from the past to the present, right? Well, how do we get from malingerers and liars and unworthy of pain equity, right? Well, we see this in sickle cell patients, right? We all have been taught, right? I think it is a standard practice in medicine to teach that sickle cell patients have real pain crises, that they actually are in pain and that we need to treat them and we need to do adequate pain management, and we should not act as if they are drug seeking. Okay, so I have been out of school for many, many years, okay, and I can tell you that I was taught that, and I know that I've been teaching at New York Med for many years, that they're being taught that, and yet I know someone who was in a hospital, not Westchester Medical Center, but was in a hospital 2 months ago, sickle cell patient, who was told that they were drug seeking. So the malingering, lying, unworthy of pain equity of the 1700s is still here. So we have to have these conversations because we have to embed this in it can't be a one-off, that they have to understand that it is ingrained, it's baked in the medicine cake, this thought process. And so I add this this particular quote, and this is, you can find this in Working Cures, Healing Health and Power on the Southern Slave Plantation. In 1859, slave owner William Massey recorded that his 81-year-old slave Patty had just died of I don't know what disease. She has been saying she was sick for near a year and always pretended to be sick. No doctor was ever summoned to investigate. Not even Patty's death seemed to have exonerated her from the charges of malingering. So again, we have a lot of work to do because this is 1859 and this picture is not 1859. Okay, and the young woman that I spoke to was 2021. So we still have a lot of work to do in understanding how the origins of inequity and in healthcare are still manifesting today. Which brings me to COVID. As Dr. Etienne said, in April of 2020, I saw this statistic, COVID's devastating impact on African Americans. And I looked at what we were seeing just in COVID. The vaccine's not out yet. The studies are being done, but the vaccine's not here. And I saw that Louisiana made up 32%, Black African Americans made up 32% of the Louisiana population, but we're making up 70% of those who are dying from COVID. Illinois, 15%, but 42% of the deaths. Michigan, 14, 41. You see the slides, you get the picture. And it prompted me to be concerned about why African Americans, people of color are dying, and why my fear was they're not going to take this vaccine based on the history of the relationship with medicine. And so when Psychology Today asked me to write something on COVID, I said I'd like to write about the collective trauma of the Black community. And they said, not a problem. So I wrote this in December of 2020. which happened to be the month that I got the COVID vaccine. And it was my hope that also that while I would get the vaccine, that I could also act as a testament to others that medicine is safe and is okay. Of course, as you know, we're still here. We're still trying to convince folks, and it's been a journey. But yeah, so so you see why it's not like they didn't wake up one day and not want to take a vaccine, right? But it is sort of this sort of innate trauma of what is of the past and what is continuing to happen. So the past never left us, right? It's weird because we're not really, we have more people of color, and we're so grateful. Look at all the wonderful Black doctors that we have on here, but we still, individuality doesn't change big systems, right? So we still have to do something to continue to have an impact on a system, and we're not going to get there in a day because we didn't get here in a day. It took us 400 years to get here. We're not going to get here in a day. It's going to take some real substantive time and effort to move this needle. And to tell the truth, what we can't do, and I did love Dr. Halpern's slide, we can't have revisited or revisionary history. We cannot have that, and we have to push back on that when we see that, and thank you for doing so. This was another slide. Again, once we got the vaccination, we saw what we suspected was going to happen, right? Is that the vaccine, the numbers of people who got the vaccine, and this is North Carolina population, white people were definitely getting the vaccine as compared to Blacks and Hispanics who were not getting it at the rate that they are the population. So we saw the disparity in that. Thank you. Any thoughts or questions on the road still yet to be traveled?
Thank you for that wonderful talk, Dr. Gardner, and taking us really through history, taking us back to the Middle Passage, then through the Revolutionary War, and to the present day. And a couple of things I want to comment on is, and anyone with questions, please start putting them in the chat while I just say a couple of things. One is, you showed the young patient with sickle cell, still being denied of their pain, and it made me think about last year, well, now 2 years ago, Dr. Susan Moore, a physician in the emergency room with sarcoidosis, complaining of pain. And she said, she on social media, she put it, I'm not getting any medications, and they made me feel like a drug addict, is what was her comment in her social media platform. And she subsequently died and felt she did not get the care that she needed. But what I want to also just touch on is, you talked about Benjamin Rush and University of what is now known as University of Pennsylvania. And it also made me think about the importance of medical education. At the time period you spoke about, really, there were two medical schools in the US, what is now known as University of Pennsylvania and King's College, which is now Columbia University. So these two institutions had the power to really educate future physicians and teach them things, and some of the things that were being taught, and it hasn't, and you're showing some things aren't changing despite our best efforts. Some of these lessons that were taught back in those days have been traveling through, including the misconception about pain perception in African Americans. So thank you for going through all those points. And I have some questions here. One of our medical students put out, how can we prevent further medicalization of oppression such as this? What allowed scientists' theories on differences between races to be so widely disseminated without concrete data? Knowing that we are still treating patients unequally with pain management, maternal mortality, et cetera, how can we as future physicians and community advocates oppose that? That's from Roy Miller, one of our medical students.
So Roy, thank you for the question. And I have a pretty simple answer for you. Is that we don't, and I'm saying collective we. So anyone, please, I don't mean you as an individual, but collective we as an institution, is that we don't always treat the person in front of us as our mother, father, sister, brother, aunt, uncles, grandma, grandpa, right? I think the reason why they were able to do atrocities was because they never saw enslaved Africans as human beings, as people, like, as their mother, father, sister, brother, and all of that. They never saw that. So if you don't, if you don't connect with someone in a real human, substantive way, and you don't see the person in front of you as your mother, your sister, your brother, if amount of melanin disconnects you from the patient, and because they don't look exactly like your mother or what have you, I think that is how you get here. This is how you end up with these kinds of inequities and disparities, because if you only see them in the healthcare as patients, in the legal system as cases, in the child welfare system as cases, as you know, if you only see them as that, then you will not, we won't be able to get out of this. Secondly, you gotta know, you have to have information, right? So part of it is that you also, while you're here, because you gotta know how we got here, because they're not, I can assure you that most of us are not being taught this history in any part of our general education from 0 to 12. And so we don't know. I mean, we know a few founding fathers, but you know, how many people knew about Dr. Benjamin Rush as a founding father and a signer of the Declaration of Independence, right? So we're so limited in what we know, because history is always written is always determined by the narrator and by the person who's writing it. So I think having information is key, and then treating people like you generally care about them, because this could be your mother or father or sister or brother in front of you. I think those are ways that we start to move the needle.
Yeah, thank you. So basically the humanism in medicine is extremely important, is what Dr. Gardner is saying here.
Yeah. And let me add this, Dr. Etienne, before we leave. And this is why academia is so important, to your point. I didn't want to miss that. Is because, right? Because the reason why this went on for generations and then they handed down is because they were such powerhouses in academia. It wasn't that they were just out here in the store, they were out here just in the middle of nowhere teaching, but they were shaping lives. So part of why we're here is because shaping lives in the beginning, when we're training medical students and residents, that's why it's important that this is part of those conversations.
Absolutely. We're going to take, I see 2 questions. I'm going to take those 2, and then we're going to move on to the next speaker. I see Jeffrey Omar Patrick, one of our recent alum from the School of Health Science and Practice. He is asking, how can we move on when the law of the land is so biased and only really consider the affluent population?
Yeah, you know what? So Jeffrey is talking about advocacy in my mind, right? Because you do have to be an advocate. I mean, people who know my work know that I advocate within other systems. And so I use my knowledge. You know, I tend not to. I'm a pediatrician by trade, but the truth is that, you know, medicine and health and these things also happen in other systems. So part of that is advocacy. So you do have to, if you see you know, sometimes people are not willing to step out, right? But you and understand that there are resources. So like I made the point about, you know, when we did some work with the NAACP or the ACLU, or we brought a faith-based panel and we had different people from different denominations and what have you, like you really do have to advocate in the big system, and don't just check, you know, judges matter, right? All these people matter. Like how many of you went into a voting booth and checked off a judge that was running and you really didn't know anything about them? You didn't know how you really picking people based on names. I mean, you are, you know, the name seems kind of familiar. You see enough signs about them, you go and choose them, you know what I mean? So, right, but like you don't really know their actual biases and things like that. So I think, you know, part of it is teaching, which is why the community engagement piece is so important, is teaching medical students, understand the communities by which they work and live, they will work and live. And also by, and at the same time, teaching about advocacy. So I think advocacy is big, Jeffrey, to your point, and it's good to see you.
Yeah, Dr. Gardner, I hate to admit it, but I remember a few years ago when I was living in Maryland, about 10 years ago or so, I came back to New York to vote and recall I wasn't following New York politics and saw a name I recognized. It wasn't the same first name, different last name. Okay.
Listen, we've all been guilty of it. Like, I'm no shame. Like, we've all been guilty of it. But some of these spaces are public. I sat in the courtroom 2 weeks ago for 4 hours, like, and just sat and watched. Like, none of that, these are not spaces that you can't see, you know what I mean? And so it may change your scope about and people will say, oh, I don't have time for that. Well, really, your life depends on it, and so does your patients, right? So it matters. Like, it does matter, like, what kind of advocate you are. Like, is your advocacy only within the walls of the room that you work in, or is the advocacy beyond those walls? It's the same thing with church. Is you advocating only within your church walls, or are you going outside of those church walls? So it has to be a little bit more than that. I'm sorry. Go ahead. What's the last question?
Definitely our patients' lives are worth our time. Absolutely. The last question from Albert Wang, who's actually in our 4th year multiculturalism and medicine course. His question is, besides implicit bias, cultural humility, and several related initiatives percolating through medical education today, are there any novel reforms being proposed to better educate and equip new doctors with skills to help heal these wrongs?
So I would say, Albert, another great question. Y'all are killing it with the questions. I think it's, if I'm honest, it's a work in progress, right? I think we're all a work in progress. I think there's some sprinkling of places that are doing, and I think we all are, even in New York Med. I mean, I'm here, Dr. Etienne is here, but it's a work in progress, because I think as a collective, and I mean the medical school systems, I think it's been a challenge, and please, Dr. Etienne, jump in here. I think in trying to figure out how to do this, right? They know they should do it, right? And they're doing some of it, right? But how do you really change a system in a real substantive way? And I say it depends on the voices in the room. So you got to have the right voices in the room. And then you have to be able to not be afraid to make big, bold changes, because the truth of the matter is that you may fail, but nothing is worse than a failure, than a try, right? So you have to, nothing is try than a failure. So you have to try, and I think that's the thing that we have. It's a work in progress, and that's all I can say. And it's in.
Absolutely. No, I agree 100% that sometimes the obstacle seems insurmountable, and that's not a reason not to try. So I agree 100% with that. And I'm going to share. I actually got my share function to work properly. So here is the information for those who are planning to claim the CME. You see that you can either go to www.eads.com or scan this QR code, or send a text message to 828-295-1144. All right, so we give you a few seconds to get that together, and then we're gonna move on to our next speaker. Thank you, Dr. Gardner, for that wonderful talk. And we're gonna move on now to our next speaker. Dr. Devin John is the Chief of Renal Transplantation at Westchester Medical Center and joined WMC in 2019. Prior to joining WMC, Dr. John served as the interim chair of surgery and the chief of transplantation at the State University of New York Downstate Medical Center. He got his bachelor's degree from Princeton University, medical degree from Mount Sinai School of Medicine, and completed his internship and residency at SUNY Downstate, followed by a transplant fellowship at NYU Langone Medical Center and a surgical research fellowship at SUNY Downstate. And I do want to thank Dr. John, because I know he recently just came out of the OR and was, which is why he's still in his OR attire, but he was able to make it to join us and give us his talk. Dr. John.
Mel, I thank you very much for allowing me to participate in the Henrietta Lacks conference. Dr. Halpern, thank you so much for a wonderful introduction and discussion, and for the passion which you share about things that we hold so dear to our lives. And for all our presenters, this was phenomenal for us to participate and learn in this extraordinary process in terms of what differences we can make within the healthcare areas. I'm going to talk about kidney transplantation, the consequence of policy. And I've been asked to talk about intentionality, and I'm not sure I am going to address that as well. But because transplantation is a more recent phenomenon, and a lot of it was because we stumbled across processes that allowed us to get to where we are now. And we made a lot of mistakes early on, and we've made a lot of improvements. Nothing perfect, but we're moving in that direction. I have nothing to disclose. There's a little review, end-stage renal disease in the United States in terms of incidence per million population. It's about 317 per million population. For African Americans, it's almost 4 times that of whites. And if you look at the prevalence, the numbers are similar. The incidence, of course, is high amongst African Americans. And if you look at it, one of the issues, transplantation is an option for many, but African Americans make between 30 and 35% of the national wait list, yet we represent about 13% of the population. And in new additions, about 29%. So we have a real burden of disease that's affected us. In kidney transplantation, comparing kidney transplantation to dialysis, it is well known that it's superior with regard to survival and quality of life, economically, as well as the best therapy for eligible candidates for this obvious reasons. Now, if you look at it and comparing dialysis to that of many common cancers that we see, you see that end-stage kidney disease in the lower part of the things on people on hemodialysis. It's like survival is quite similar to that of digestive system cancers or brain cancer. And if you look at kidney transplantation, you have much better outcomes overall. And this is a far better cry than anything that's available. Now, in terms of cost, the estimated cost to the amount of money spent on chronic kidney disease and end-stage kidney disease without transplantation in the United States is about $50 billion a year. And that includes Medicaid, Medicare, VA insurance, and other private insurances. If you look at the total cost of kidney transplantation, it's about $5 billion. And you can see this is a magnitude difference in terms of the cost. So transplantation is far cheaper and better outcomes, and so that makes sense. So all these concepts were around in the 60s and 70s when we first started doing transplant. First transplant done in 1954, and we as a community, as a transplant community, recognize this, and we presented a lot of this information to the federal government. And in 1972, for the benefit of patients, the Social Security Amendment at that time in 1972 entitled all U.S. residents access to end-stage renal disease, and those who are permanent residents and citizens access to transplantation, which implicitly guarantees equal access and optimal treatment when it comes to transplantation. So as a result, you can see, since we started keeping data in 1988 to 2020, you can see that the number of transplants in this country have steadily gone up. And in 2020, the full data is not there, but we did over 22,800 kidney transplants in the United States. And last year we did more. I don't have that data here because it wasn't all fully compiled. So what happened? In the 1980s, the federal government realized that many centers were doing transplants around the country, and you need some degree of regulation since the federal government was paying for some of this money in the form of Medicaid and Medicare. So it came up with the National Organ Transplant Act of 1984. This was by Health and Human Services, which developed an organization called the Organ Procurement Transplant Network, which then contracted the United Network for Organ Sharing, otherwise known as UNOS, which went into place in 1988 in full regalia. And as a result, it became the National Regulatory Agency for Organ Allocation and Candidate Registration. And of course, we as a community, physicians and healthcare practitioners, as well as people from the community at large, participate in terms of policy development, procedures, and the like, and what was required by the federal government, and which was key to the entire process, and which really helped us, is data collection and presenting outcome data. So some of the key issues associated with the allocation process in terms of policy in allocation was wait time. Wait time was dated the date you were listed back then, okay? We looked at blood type compatibility over blood type specificity, meaning O blood type can go to anyone, A can go to A and AB, B to B and AB, and the like, and AB only got from AB. The eligibility for kidney transplantation came at a chronic kidney disease stage 4, and which means a glomerular filtration rate less than 20 mils per minute. And there was a scaled matching priority based on human lymphocyte antigen, or the HLA, or tissue typing, where there were 6 antigens to match. If you were a perfect match, you got better priority than if you had 6 mismatches, you had less priority. And then there was known that many of our patients were very sensitive because of previous pregnancies, of blood transfusions. We gave priority to those who had high sensitization, meaning 80% or higher, based on a general population evaluation, and gave some additional points to that. But anyone less than that didn't get an additional points. And then geographically, allocation for deceased donor organ was based on this weird geographic process that raised many questions at the time, and a lot of discussions over the years. But this is how we went forward from it. No one understood what it all meant until we started looking at data. Now, since this is Black History Month, I'm going to comment on some of the pioneers in transplantation. The first is Samuel Kuntz, a man I call my hero because he was from Lexa, Arkansas, a town of maybe 400 people, and he went on to medical school and in Arkansas, and went to Stanford, did his general surgery training, and became one of the first transplanters in the world. He was the first African-American transplanter. He helped pioneer, who participated in the second successful kidney transplant in the world. He helped pioneer some of the techniques in transplantations, immunosuppressive medication, organ preservation. He went on to become the chairman of surgery at Downstate Medical Center, the first African-American chairman in a traditionally a Black university or college. He made a huge deal in the whole process. Clive Callender also was the chairman at Howard University, also a key player in transplantation, where he increased access to African Americans, increased organ donation amongst African Americans, and made a lot of noise on a national level when it came to policy and poor policy practices. And Velma Scantlebury, the first African American female transplant surgeon in the country, and I think she recently retired. And she had made some significant contributions, not only in the areas of policies and discussions, also in some of the techniques with liver transplantation and organ transplantation. Going back, so what affects us? There is a huge need because of the burden of disease for organ transplantation. We have higher rates of organ failure, particularly in kidneys. We have fewer preemptive referrals. I'll talk more about that. And when it comes to allocation, we have lower rates of living donor allocations, and that's because many of us have the same disease as our sick members of our family, and we have low incidence of deceased donor organ receipts, and we have poor outcomes. This is the burden that we deal with. And the question is, why does this occur? And why did it occur? And why does it continue to occur? So what are the sources of disparities? There is a complex process, and some of it starts even before you get in the door for consideration for transplantation. You may be sick, so the pre-referral process, there are patient factors for fear and poor education as part of the process. There's provider bias, and I'll talk more about that. There's also where you live and the rates of referral. Interesting enough, neighborhoods with high density of end-stage renal disease have poorer referral rates. They also tend to be poorer neighborhoods and neighborhoods with higher density of people of color. The issue of, estimated GFR, as we know, that's an issue that has come to light more recently. That in itself has its own issue. Once referred, the process of navigating this complex process of being evaluated and listed for kidney transplant can be extraordinarily difficult. And there's provider bias and policy bias along the ways within each institution, as well as national policy bias. And then there's, once listed, we have issues within terms of blood type and HLA polymorphism, where people of African descent have greater degree of HLA variants than those from other regions of the world. Allocation policies affect us, and I'll talk more about that, as well as access to living donor. So as we go through the process, what did we find? Of years of studies looking at some of the data going back to the 90s and early 2000s, we noticed that African Americans are less referred. They're less identified as a potential transplant candidate, particularly in the first year of eligibility, based on CMS criteria. They're less likely to appear on a transplant wait list, and were less likely to receive a transplant, particularly at a rate 24% less than those of whites. And many of us started looking at this and trying to figure out what the issues were, and we started to address it based on policies. So before we even get listed, before we get referred, let's take a look at one of the issues: chronic kidney disease stage 4. Okay, this is where people meet the eligibility. African Americans are less likely to be referred in the pre-dialysis phase of this process, which means by the time we get referred, we're already on dialysis. We wait longer on the wait list. And this impact, at least dialysis vintage, has a particular impact on the proportional risk of morbidity, mortality, both while waiting for a transplant and after you receive a transplant. And this in itself has a significant impact on outcomes, okay? So we have, and as a result, because of the waiting time starts at the time you get listed, we get listed at the time we referred, or and that's when waiting time lasts. And most African Americans are listed at time of dialysis. They tend to wait on dialysis much longer before they get a transplant. One of the big issues in policy allocation was this whole issue of donor service area. There's 75 around the nation. Each one, there is no uniformity to donor service area. They have variable population densities, variable coverage areas, they have variable densities of end-stage renal disease, they have inconsistent rates of organ acquisition and transplantation. For instance, our donor service area within the New York area includes all the New York City counties, all of Long Island, Westchester, Putnam County, Rockland County, and Orange County. And what's the county? Columbia County, I think, whatever is above us. That's our donor service area. Okay, so what does it mean? It means that organs within our area are shared first. Organs that are acquired from our area are shared first within our area. If it's not shared in our area, then it goes to region, which is also was arbitrarily defined. Those are 11 regions around the country. And if it's not used in the region, it's then used nationally. So what does a region look like? So some reason back in the 80s, they decided to divide the country into 11 regions. Region 1 being the New England area. Region 9 is New York State, the only region that's a single state. Every other regions have broader states and broader coverage. And again, one of these arbitrary things that were defined. And why this became the case, we're not sure, but most likely it was related to the major transplant centers, which were located in areas like Minnesota, and Pennsylvania and California, who define these things, and Texas. Interestingly enough, access to organ transplantation is equivalent between whites and blacks in Region 1, New England, and Region 6 in the Northwest. Other areas have a great degree of disparity, and the worst being Regions 3 and Regions 4, that is the Deep South in Florida, and that's Texas and Oklahoma areas. Looking at this study breaks out the country into counties and looking at the relative rates of donation, organ donation by county within the United States. And you can see the majority of New York State is red, meaning lower rates of organ donation. And the blue areas are higher rates of organ donation. You can see that, South Jersey, Eastern Pennsylvania, somewhere in the Midwest out here, and Michigan and so forth have higher rates of organ donations within these regions. And what affects the rates of organ donations? One, population density, the age of the populations, availability of healthcare facilities. In the New York area, we have a high density of healthcare facilities, particularly in the southern part of the state. The attitudes toward organ donations, particularly amongst those who amongst the general public, as well as the healthcare community. The causes of death has an impact in terms of trauma versus non-trauma, and where in the New York area is higher rates of stroke or cardiovascular reasons. And the other issues is belief systems, where some belief systems have a difficult time in terms of organ donation. More recently, the United Network for Organ Sharing then broke it down state by state in terms of the ability to receive an organ transplant within 5 years of being listed. That is for a deceased donor kidney transplant, not a living donor. And the lighter the color, less likely you ought to receive one, and the darker the color, more likely to receive one. And it looks similar to that of the counties based on that. And you can see that New York State, like New England's poor, California's poor, and certain areas are poor for whatever reason that may be. And if you broke it down by the 57 donor service areas around the country, you can see how variance in size some of these donor service areas are, while ours is a very small area here in the New York area, but though we have a high population density. Looking more closely at New York, you can see our rates of transplantation, at least getting a transplant within the first 5 years after being listed was very low. Okay, so what does it tell us? One of the key things it tells us that where there are higher rates of end-stage renal disease, you tend to have lower rates of transplantation. Two, high metropolitan areas of high density and high demand, it's hard to get an organ transplant. And because of donor service areas, organs that are in New Jersey or Connecticut, which have higher rates, or upstate New York, typically won't cross over to the area with higher population. One of the issues that's caused a great degree of consternation within the transplant community, and I myself had significant discussions with some members of our community who live in the Midwest and other areas where higher rates of organ donation, and they said we should take care of ourselves. And my question to them at that time was, so you're saying that the organ is a citizen of the region, or at least the local donor service area? And the person said, yes. I said, in that sense, then we should apply the same reason when it comes to taxes and income. I said, in this 8 square block area in Lower Manhattan, we generate hundreds of millions of dollars a day, which is taxable by the federal government. By your argument, New York or Southern New York should just keep the money to ourselves. Is that correct? Now, he got very upset about that. I said, it's the same argument, but that then led on to other discussions and other changes later on, which I'll talk about. Estimated GFR, glomerular filtration rate. GFR reflects the degree of renal function. Better your GFR, the better your renal function. What qualifies you a transplant discussed earlier is a GFR 20 mils per minute or less. Now, the best or the gold standard is to get a measured GFR, and to collect urine over a 24-hour period, or to deal with using nuclear medicine as a testing is very complicated, and there's a lot of room for error that goes into the process. So what we rely on is a surrogate, and that's estimated GFR, MDRD, or other techniques which are been in existence. In the process, it's an assumption that African Americans, people who are who define themselves as African Americans, and where that for any given EGFR, we have higher rates of, for any given creatinine, I should say, there's a higher rates of glomerular filtration rate, or higher rates of function when compared to whites for any given creatinine. But this is not necessarily accurate, and it's very variable. There's a large overlap between the groups, And as in more recently, a lot of discussion within the literature as well, not only within the medical literature, but also within the public. This is not, this has been sort of like an unfavorable way of looking at things based on race and leading to, not necessarily leading to good outcomes, but sometimes poor outcomes. It is influenced by diet and body habitus. And as a result, many African Americans are referred at a later point in time because of this factor. And it's still used today, but we'll get to that later. Regulations. We develop regulations to standardize care across the entire transplant network. And CMS in 2007 developed a whole system of conditions of participation. And this is enforceable by law. If you break the conditions of participation, the FBI may visit your transplant center or your organ procurement agencies. It is applied across the board. It allows programs to be certified. If they do not meet the requirement, Medicare can refuse reimbursement and close the program as a result. It provides a sort of like a guidelines, or at least a law for multifaceted assessment of our potential transplant candidates based on medical evaluations, psychosocial evaluation, and financial evaluations. And it's a multidisciplinary team approach. And social workers or psychiatrists are part of the entire process, and social workers must be part of the entire process. So what does it mean? The psychosocial evaluation requires, at least the minimum requirement is that the social worker or whoever the psychosocial evaluator is must look at a minimum, the housing, location and financial status of the patient, as well as the environmental support system. This becomes a very vague area because this becomes an odd process of how we evaluate our patients. And when it comes to Black patients, we're 12 to 25% less likely to be listed for a kidney transplant based on psychosocial reasons. And for those who are made inactive because of psychosocial reasons, they're 70% less likely to have this issue resolved. What are the barriers? They're well known. And the support system that we have as a community are strained because many of us are on hourly wage. And we have a lot of care given for responsibilities. And that because of this hourly wage issues, we're not guaranteed sufficient time off to be evaluated, to come to a transplant center, to be seen in a timely fashion. And some transplant centers in the local in our area, if a patient is not seen or complete the evaluation within 3 months, they will be deferred or dismissed as a potential candidate. Others centers recognize that this is a difficult problem within the community and take time to make sure that the patient gets listed, and sometimes it takes as much as a year. The other issues, we want to get evaluated. We may not necessarily have the resources to help support our networks or our children. And there's a wealth gap that's impacted. Marital and family ties are sometimes destabilized due to economic and racial marginalization, as well as issues of mass incarceration, which has affected many of our patients within this community here in Westchester. Support networks are smaller and are challenged by residential segregation and decreased mobility. And our social workers or our healthcare providers are oftentimes entirely too subjective and results in a disproportionate blocking of people of color from getting on the transplant list. Now that we've overcome that, then we have biological barriers. We have a policy that's in place that looked at blood type compatibility back in the 1980s over blood type specificity, meaning O blood type can go into A, B, or AB, and A into A or AB, a B into A to B or AB. And to that degree, you look at it closely, they didn't take into account the frequency of blood types within different, ethnic groups or the diversity of blood type across the world and where blood types fall, how they fall into that criteria, such as amongst Blacks, O and B are higher rates of frequency, while amongst whites, it's O and A. In so doing, by diluting out the O blood type, you decrease the availability of O organs to O recipients. And you also decrease the availability of B organs, the B recipients, if it's so low in the population, it's a rare blood type, by giving it to both B and AB. So all this has an impact in terms of how this policy affects, but I'm not sure they understood it at the time. They decided this was a great idea to get as many people transplanted as possible who was eligible. Now, the degree of HLA matching or tissue typing, organs are allocated based on the degree of mismatching. If you have 0 mismatching, you get priority. If you have 6 mismatches, you get less priority. So what's the impact of all of this? Blacks are disadvantaged over the higher degree of O blood type and B blood types. Now, the majority of the organ donor pool are white because of based on population dynamics. 60% of the organ donors are white. About 15% of the organ donors are Black. Okay? Higher rates of blood type A means if you're blood type A, you're going to get a transplant pretty quickly. And if you're blood type O, you're going to wait longer. If you're blood type B, even much longer, as much as 60% longer. Looking at HLA matching, on the left, you can see that if you're 0 mismatch, looking at 5-year graft survival, this is death sentence graft survival. If you're 0 mismatches, you have the best survival. If you're 6 mismatches, you have the poorer survival. And that's between, this data was collected between 1985 and 1994. And even before they saw this variance, before the advent of some of the newer immunosuppressive medications, such as tacrolimus or calcineurin inhibitors and other medications that are available in the market, which then, after 1995 and even more currently, narrowed that gap altogether to the point where this variance did not matter as much, okay? Survival statistics look quite similar across the board, except for maybe 0 mismatches. Despite having this knowledge, there's still a high degree of pushing towards keeping the system in place. We looked at it closely and realized, actually I did something wrong, sorry. Look closely, sorry. Am I doing the right thing? Sorry, I'm sorry about that. Okay, so one other thing I forgot to mention is that amongst African Americans, we have a high, or people of African descent, a higher degree of polymorphism and less degree of matching when comparing that to whites. As a result, many of us wait longer on dialysis and more likely to get blood transfusions, and therefore we get sensitized at higher rates. Not necessarily up to the 80%, but it decreases the ability to get an organ transplant because of positive cross matches when an organ becomes available. So looking at data from 2001 and looking at the previous policy, what did we see? We saw that African Americans made up 35% of the wait list. We saw that a number of deceased donor kidney transplants which were done amongst African Americans were only 22%. And African Americans waited significantly longer than when compared to whites, which made up 38% of the wait list and received 60% of the kidneys and waited a shorter period of time. Of course, many of us were up in arms at the time. We brought these issues to the Board of Governance for UNOS and everything, and there's a great degree of discussions back and forth. And then some changes were made, such as O blood type only to O recipients, B blood type only to B recipients. And we got rid of some of the AB, HLA matching, and kept the DR or class 2 in place. But despite this, and then narrowing of the gap to some degree, there's still at a high degree of disparity between organ allocation and rates of transplantation, as well as listed patients. So this circumstance looked very, very bleak. And our awareness led to outcome studies, a lot of years of advocacy at many levels, and at the regulatory levels, in national meetings, and many papers were written about this, and many discussions came about. Then came Health and Human Services put out something called the Final Rule. This came out under Secretary Hla, who was, I think, the secretary with the New York State Department of Health around that time, before that. And being a New Yorker, she knew a lot of the arguments that New York has presented to the process, and then changed the dynamics of organ allocation and updated the regulations. Though this process was in place, or at least initially discussed as far back as 1994, many lawsuits and many discussions and many blockages at the level of at the national level when it came to regulations got in the way of the entire process, and she pushed this forward. She put forward, at least Health and Human Services put forward, that allocation should not be based on a geographic proximity, but favor and prioritize the patient needs on a much broader sharing basis. Why is that the case? Organ preservation was fairly advanced. We could transplant organs across the country and keep, like kidneys, on a preservation pump, on preservation solutions for more than 24 hours, and it worked just as well. And we knew that very well. But everyone used these little tweaks just to keep it back. They also updated the regulations, and we talked about that early, where United Network of Organ Sharing had a new set of regulations that they must be answerable to the federal government. The organ procurement agencies, such as in the New York area, Live On New York, transplant centers, as well as personnel, we must be monitored, we must have oversight, we must be accountability, and if we don't meet the requirements, we are at risk for defunding and or closing and or having law enforcement taking a look at us. This policy went into place in 2007, and part of the policy required that all dialysis centers must refer patients to transplant centers. It was not required before that. Transplant centers must develop outreach programs and reach out to dialysis centers. Since we're interested in doing transplants, and dialysis may be interested in keeping people on dialysis, they figured that we perhaps have better interest in trying to discuss the process of transplantation. They set up a specific guidelines to evaluation and educational requirements, which can be reviewed and audited. This resulted in increased rates of referrals and a narrowing of the gap when it came to transplantation in the long run. Later on, the transplant community at UNOS, United Network for Organ Sharing, the kidney committee, took 10 years or more to develop a new system of organ allocation policies, where start time on the wait list, particularly for those who were not referred early, started the day they started dialysis, therefore addressing the inequity in terms of late referrals and try to reduce the risk associated with transplant of our dialysis vintage, therefore to decrease the rates of death on the wait list or deaths related to dialysis in general. They developed a sliding scale point system when it came to sensitization. It's no longer based on 80% alone. Wherever you start, there's a sliding scale. And for those patients who have exceedingly high sensitization rates of 98%, there's required national sharing, so they have access to organs around the country. Zero mismatches can only be shared locally, not nationally anymore. A2 blood types, which looks like A but behaves like O, can be placed into B recipients, which reduces the B blood type wait times. Removal of those HLA-B points altogether, and what it did was level the playing field. And in fact, what it did, took a balance between utility versus justice. In the past, the issue of organ allocation and transplantation was sort of like based on what they thought was a utilitarian approach, particularly when it came to HLA matching. And now we look at a more equitable distribution and try and look at accountability based on that, so we can all take a look at it and see what the outcomes are. So what happened? Early on, the rates, these are percentages, the rates of transplantation, looking at the rates of transplantation amongst whites declined. I mean, the wait list rates of whites declined while the wait lists of blacks increased. The total number of people on the wait list have declined because of better management of diabetes in more recent years, the rates of listing amongst Hispanics increased as a result. You can see the rates of transplantation early on narrowed, and then there's an increase overall. And this increase amongst whites was related to availability of living donor transplants, where whites account for about 64% of the rates of living donor transplants, while blacks account for about 13%. But looking more specifically at rates of deceased donor transplantation, you can see where the gaps amongst whites versus blacks and Hispanics were wide, it now narrows and they sort of like mirror each other. all because of this policy change. Okay. Geography, that weird definition that we once had, we changed the system, and this went into place March of last year. It was supposed to go into place March of 2020, or actually before that, there was again more lawsuits around the country. COVID delayed the implementation in March of 2020. We put it in place in March of 2021. What did it mean? We removed this donor service area definition, okay? We allocated organs based on the location of where the donor is. If a donor, in this case, is in Philadelphia, that donor is in the hospital in Philadelphia, a 250 nautical mile radius is drawn around the donor. Anyone who's on a transplant list in that area has access to that particular donor. And if you shift this up to the Westchester area where we are, we now get calls for organs as far north as Maine, as far south as Virginia, and as far west as Ohio, which increases the area in which we get organs to transplant our patients. So points are given to patients who live closer to the donor. This then improved the efficacy in terms of prioritizing who the recipients are. It encouraged broader sharing, normalizes wait time. So the wait time in New York, the New York City area, used to be like anywhere between 6 and 8 years. Now it's supposed to normalize and reduce that. We don't have the data yet, and the outcomes are dependent on that. What, in my experience, what I've seen as a result, our rates of transplantation, kidney transplants in the New York area, particularly Westchester, has gone up. We're transplanting at higher rates. Our patients are coming off the list faster as a result, and we are very happy to say that is working out very well. So we're looking for the data on this when it comes out, and when it's collected by United Network for Organ Sharing, and we should get some of that data sometime within this year. EGFR, we know it's inaccurate. We know that many institutions around the country have stopped using the African American variant and looking for measured GFR or using more accurate measures of compiling serum creatinine with cystatin C, which is not influenced by muscle mass or diet. Though it's more costly, there's a high degree of hesitance to use it because we're not particularly familiar with it. But there's a move towards this to increase the accuracy of renal identifying appropriate renal function per individual. On a national basis, transplantation has not moved towards this yet, but I'm sure that we'll move towards it eventually. I am hopeful, and that shouldn't say I'm sure, I'm hopeful that we move in that direction. Psychosocial evaluations. This is a tough area because this is so subjective. We need to be less subjective, be more aware as a community, as a whole, and protect equal access to healthcare to all our potential transplant recipients. The system promises equal share across the board, and we need to use the limited resources we have equitably. We must take into considerations and not penalize our patients, their social circumstances, for whatever reason it may be. And oftentimes, many of our practitioners are not equally as aware of who we are as a community, and we need a better education and more advocates to make sure this occurs. So, in summary, and I hope I covered this whole process of how policy has changed over the years. We have excellent outcomes when it comes to transplants. Our initial policies were terrible. Many times were made without thought to the process of what the outcomes were. Through years of advocacy, almost 40 years of advocacy, and a lot of fights within many members of the community in transplantation, we've gotten a more equitable allocation system and fairer access to transplantation. It's not perfect. We have a lot of areas to address, particularly center-based practices, and we need to be more, and this awareness that we've had over the years have led to good research, and that research had provided us the data to then put in front of our colleagues, and as well as the regulatory bodies, to then change the policies nationally and locally. Thank you very much. If you have any questions, I'd be happy to answer them.
Yeah, thank you for that great talk and really showing the impact that health policy can actually have on our patient outcomes. And this definitely hits very close to home for me because I actually have a cousin who recently had a kidney transplant, and I recall her getting the phone call and the excitement she had, and I was the one to go pick her up and had to get my car seat out of the back so that her mom could come along, which was a little bit of a challenge. But I think people, when they get that call, feel like if we don't get there right now, we're going to lose that opportunity. Although I'm sure that the kidney will be there waiting for her whenever we get there. But yeah, I remember that feeling, and really just remarkable to see the impact that this policy has had on health equity, which shows us the importance of a multi-pronged approach to leveling the playing field for our patients. Are there any questions right now? Okay, I don't see any questions, which is great. Maybe later on there might be some questions, and they'll give us an opportunity to hopefully get back on track because we were a little behind schedule.
I'm sorry about that.
Oh, I see. Dr. Gardner, did you have a question?
I do. I have one question. Can you elaborate? I know you talked about some of the eligibility in regards to the GFR. Can you speak about what should people be doing to get evaluated earlier, since the eligibility is the eligibility, right? That hasn't changed, but what can happen earlier so that they're not lingering on dialysis later once they reach the eligibility point?
Well, most people who are on dialysis, the dialysis centers are now required to provide a list of patients who they refer to for transplant evaluation, which means all should be, unless they have medical reasons or some contraindication of transplantation, such as active cancers or certain active infections and the like, or certain cardiopulmonary disorders that make it prohibitive for them to be transplanted. So therefore, dialysis centers are then referred. Transplant centers around the area and around the countries are very aggressive in terms of recruiting patients to get transplanted. So that's not where the weakness now lies. The weakness now lies for people who are pre-dialysis. And one of the issues that affects many members of our communities is, particularly amongst men, is that we do not seek medical attention on a regular basis to be evaluated to see what our renal functions are, and oftentimes show up in the emergency room with kidney failure. That's one thing. And that's awareness within the community as well as outreach within the community to make sure that we are seen by a physician on a regular basis and get regular checkups. The other issue is that in the past, where privately owned dialysis centers tend to hold on to dialysis patients and not transplant them, not send them to transplantation, all of that has been exposed in many articles, particularly in New England Journal of Medicine, an article back in 2000 that sort of like embarrassed many of the privately owned dialysis centers. So that has then changed in terms of policies, and CMS has put out some very aggressive requirements about that. Physicians should refer patients early, particularly to nephrologists, and nephrologists oftentimes refer their patients very early to us, but not all. Again, this is based on personal bias and belief systems. Some nephrologists want to think they can prevent people from getting on dialysis and hold them off, but we strongly encourage advocacy as well as awareness across the board.
And can I ask a follow-up question to that? Then how do we get, because I also see that within the Black community, that kidney disease is seen as something normal. I mean, in a lot of ways, like they feel like, they know someone who's got a kidney problem or whatever. So, also I think there's a portion of that, like very much like diabetes. Well, Black people get diabetes or Black, you know what I mean? As opposed to, so how do we like change that mindset of thinking that like this is sort of normal in these communities when, disease is not normal?
Yeah. I agree with you. Disease is not normal, and oftentimes we are lulled in the sense of complacency because, as you discussed earlier, of fear of seeing a physician, that phobia, and oftentimes it's been promoted by past history, and many people think some people think this entire process is experimental. Again, it's educational and awareness that has to start from day one. And often when they see their physician, if we see our physician, is one of the things. I many times do a lot of advocacy processes and education processes within churches or community-based centers where I know people, where people reside. But what do I see? I usually see women, and they tend to be more educated and tend to be more aware. The groups that I have the most difficult time with are men, particularly the younger men. And these are some of the difficult barriers that we have to overcome. I wish I could answer that, you know.
Yeah, no, thank you for shedding light on those challenges, and definitely a lot of people start to normalize disease. Now we're going to actually transition to a mental health, where oftentimes people deny that this is even a problem. So the next speaker is Dr. Olanruaju Olukatibi. Dr. Olukatibi was born and raised in Nigeria. He completed medical school at the University of Ibadan College of Medicine in Ibadan, Nigeria, where he graduated in 2005. He worked at the University College Hospital and also hospitals affiliated with the Federal Ministry of Health in Nigeria until 2008, when he came to the US to pursue his Master's of Public Health at the Rollins School of Public Health at Emory University in Atlanta. He graduated with his MPH in 2010, worked at Woodhull Hospital in Brooklyn, both as a clinical chart review officer and a coordinating manager in the Division of Quality Management between 2011 and 2014. And then he entered psychiatry residency at Harlem Hospital, where he served as chief resident in his final year. Dr. Olukatibi started working at Garnet Health Medical Center as inpatient psychiatrist immediately after completing his training. And then now he's works for Good Samaritan Hospital, part of the WMC Health Network as the consultation liaison psychiatrist in February 2021. He is married and has a wife and 2 children, ages 8 and 6. Please welcome Dr. Olukatibi.
Good evening, everyone. Can you all hear me?
Yes, we hear you.
Okay, good. So I'm Dr. Olukatibi. So I have no financial disclosure to disclose and no nothing. Next. So I will just quickly run over these topics: definition of Black community versus person of color, the medical history, recent statistics, substance abuse, technology and therapy, biopsychosocial model, then also trauma-informed therapy, and also practical applications. Next. Now, I'm aware that this presentation is actually tailored towards medical students. So I will bring specific examples to help them in their training and in their future medical practice. In addition to that, to save time, and some of the previous speakers, they've talked on some things that I will just gloss over and quickly move over to save time. So what is Black community? It means that all persons of the African diaspora, including African Americans, the Caribbeans, the West Indians, the Latin America, and African people living in the continental United States. And actually, I belong to that last group. I'm an African, I'm Nigerian, as Dr. Mill informed you guys. So that is the Black community. Most people of color, the example I try to use is that they always have they have an affiliated rice. For example, like the food rice, we have the African rice. In Africa, we have the Nigerian rice, we have the Ghanaian rice, we have the South African rice. We have the Caribbean rice, we have the Latin American rice, but apparently we don't have what we call European rice or the Caucasian rice. So I use that. So any tribe or any region that has a specific rice, there are probably a people of color. Now, the next slide talked about the medical history and Tuskegee, the syphilis study. So this has been discussed extensively by the previous speaker. But what I would like to bring up in this is that this study went on for 40 years, between 1932 and 1972. However, between 1946 and 1948, there was this Nurember code that came up following the Nurember trials, in which the American military actually tried some German physicians that used people living in concentration camps for studies, and they placed them on some sterilization laws without their consent. Now, what this means is that the American military, they were involved in trying to make sure the Jewish community were not being abused, whereas during that same period, the Tuskegee study was ongoing. So there was the bias against the Black community where this study was going on. However, the government was trying to help out the concentration camp, people living in the concentration camp in Germany at that point. So, and the Tuskegee studies continued for up to 3 decades after this Nurember Code, which states that there needs to be a voluntary consent of the human participant is absolutely essential. This was not observed, this was not taken into consideration. And we talked about what the first speaker talked about, intentionality. Was there an intention, even though they knew what was going on, to just continue to use the Black men for this study? So it's the racial bias. It is bad. There's no other way to call it. But we've talked about it extensively. So I would like to move on to the next slide. Next. So, and also we all know about Henrietta Lacks, how our cells were used for many studies ongoing without the family being known, being told. So next. Now, what I want to focus now more and talk about is the medical history. So the topic of this is the truth about mental health in the Black community. So as a psychiatrist, most of the time when a Black man receives a diagnosis of probably schizophrenia, there is likelihood to associate it more with other diagnoses like mood disorders or PTSD. Or a Black man is more likely to be that has anxiety or depression, might be misdiagnosed as schizophrenia. It is very high, it is more prevalent for a Black man to be given a misdiagnosis compared to the Caucasian. And there's a rule of thumb in the past that says if schizophrenia is on the differential, you should also include bipolar disorder, especially for Black people. And the Black people might not even meet that criteria. So it was ongoing for a long time until recently when the APA decided to really knock down on it and to try to eliminate this bias. Next. So talking about medical history, why there is this culture of distrust that the Black community have about the medical society. And this stems from the Tuskegee studies up to now because they feel that they cannot trust the system. So as medical students, you need to understand that the Black patient that you're seeing in front of you already has a level of mistrust of the medical system. So you see a patient in the clinic, in your office, is talking to you, and he's a Black man. Already he has this mistrust. He doesn't trust the system. He doesn't trust you, especially if you are a Caucasian. The patient will not trust you because of where they are coming from. So there's this distrust of patient towards the medical system. Now, in statistics, 25% of Black Americans seek treatment for a mental health issue compared to 40% of white individuals. And this is mainly due to mistrust. They don't trust the system. So as medical students, you need to be sensitive to this idea that this patient in front of me that is African-American, that is of the Black background, has a mistrust of medical treatment that I want to offer. You need to be aware of it. You need to be sensitive about this so that you can deal with it appropriately and you can gain their trust. Now, because of this distrust of Black patients towards the medical system, they usually prefer to use social support to address their medical needs. They talk to families, they use friends, they use faith-based groups, they use life coach, and it is due to fear of stigma or fear of misdiagnosis. Some of them, they believe that whenever they go to see a psychiatrist or a mental health professional, they are more likely to be diagnosed with some schizophrenia, and that is scary to the community, when actually they may really have anxiety or panic disorder. So because of that fear, they will not seek medical attention. So for those that you get to see in your practice, whether you don't have to be a psychiatrist, you need to be aware that there is an underlying distrust that this patient has. So if we have that at the back of our mind, we'll be able to help them and also allay their fears so that they can trust us. Also, there's a physician or what I call clinician perpetuation of the medical system. So Black patients, they are 2.5 times the odds of being described with one or more negative descriptors in the electronic health record compared to white patients. So Black people are more likely to be labeled with negative descriptors, and which we all know. Now, there's a study that I'd like to talk about, which has been talked about before, is the Hoffman study in 2016 in Virginia. So there was this belief that Black patients, they have thicker skin, and so as a result, they can withstand more pain, and thus they are given less pain medication to manage their pain. And the study actually involved medical students and residents, and there's this perception that Blacks can withstand more pain, so they are not properly treated. And I believe one of the speakers talked about a patient, a sickle cell patient that was in the ER and was not given enough pain medication. So we need to be aware that this is inherent. This study was done in 2016, which is recent. So it's not like in the 18s or in the 1990s or so. It is recent. So there's this perception, and it is a misconception that Black people, they have thicker skins and they can withstand more pain. And because of that, they are not properly treated for their pain. And that is not right. Then also there's a report about opioid death related to physicians under-treating pain in Black patients. Now, Black patients with schizophrenia, they have a higher rate of incarceration compared to the white population. So a lot of mental health patients with schizophrenia are being incarcerated, and they are not receiving the proper mental health treatment. They are supposed to be in the mental health institution being treated. They are supposed to be seeing a psychiatrist, a therapist, a clinician to address their mental health, but they are being incarcerated at a higher rate, and their mental health as a result are not being addressed. So there's this distrust that the Black people have towards the medical system, and there's this perception that the medical system have concerning the Black people. So we need to be aware of this distrust. We need to be sensitive to this so that we can move forward. Next. Now, when we talk about mental health in the Black community, it must be one that is trauma focused. As we know, the Black community has been exposed to a lot of trauma within the community, including the police brutality, including the way they felt they were being used for experiment without their consent. and also due to the biopsychosocial factors due to low income, poor housing, and living in much more violent environment. So most of if you're talking about Black community and mental health, it must be one that is trauma focused. Trauma is at the bedrock of the origin of the mental health. And if you want to address the mental health in the Black community, it must be one that is trauma focused. Now, trauma is an event or an experience and is rather than an illness. And does being Black mean that you are inherently traumatized? Now, we know that patients that suffer from PTSD, or we know that PTSD can be, it is inheritable. So a patient, the younger generation might not have been exposed to those trauma, but because they are descendants of the families that were exposed to trauma in years back, so there is this possibility of them manifesting this traumatic event in form of mental illness. So if you want to address this mental illness, it has to be a trauma-focused and trauma-informed therapeutic intervention. If trauma is not involved, we will not make any headway in addressing the mental health within the Black community. So it is one that is trauma-focused. I'd like to emphasize it a lot. Now, also in the Black community, there's this thing about resiliency can lead to stigma. We are being told that the Black community is being told that you should be tough enough, you have a thicker skin, the Black man should not talk about being mentally ill. It is a taboo to talk about. And in some ethnic groups, in some ethnic groups within the Black community, you don't talk about mental illness. If you talk about depression, you might be ostracized. So there's a lot of issues going on, and all these need to be addressed. Next. Now, according to the APA is American Psychiatric Association, it shows that African Americans often receive poor quality of care and lack access to culturally competent care. Only 1 in 3 African Americans who need mental health care receives it. Compared with non-Hispanic whites, African Americans with any mental health have lower rates of any mental health service use, including prescription medication and outpatient services, but higher use of inpatient services. And I would like to talk more about this. Before I joined Good Samaritan, which is part of the Westchester Medical Center Health Network, I was an inpatient psychiatric. And I noticed that in the community that I was working, the African Americans, the Black community is about 10%, but our inpatient services always have almost 50% people of Black origin, Black people. And what I noticed was that outpatient psychiatric services and prescription medications are more readily available to the non-Black community, and the Black community, they are not that exposed to the outpatient psychiatric resources. As a result, we have a higher number of Black people in the inpatient psychiatry services, which is usually, most of the time, it's an involuntary admission. So as a result of that, they keep going back to the inpatient unit because they do not have access to outpatient psychiatric care. Now, one study found that physicians were 20% more verbally dominant and engaged in 33% less patient-centered communication with African-American patients than with white patients. Now, what this means is this. As a psychiatrist, when I say patient, because I'm Black, I understand this, but many other people that are not sensitive to what the Black community have gone through, whenever they are interviewing them and they talk to them, they kind of talk down on them as if they are a nobody. The conversation between the physician and the patient is very verbally dominant, and the Black people, they become more scared. And because they become more scared, they will not come back. And because they will not come back, they will not follow up with whatever outpatient, with the limited outpatient psychiatric services that were provided for them after they were discharged from the inpatient. And also they will not take their medication, and they will decompensate psychiatrically and then end up being readmitted. And part of it is the way the physician talk to them. They don't treat them with that sense of humanity. They look down on them. And that is why it's important that the medical student, they are aware of the fact that the way you express yourself to this patient when talking to them, you don't have to be a psychiatrist. It could be during your medical rotation, surgical rotation. Treat them like human being. If you treat them like human being, they respect you more. They become much more confident. The mistrust is diminished. They are more likely to listen to your plan, to your aftercare plan. So, but one study found out that the Black people were being verbally talked to dominantly in about 20% more than their fellow non-Blacks. And also, as I said, there is a 33% less patient-centered communication with the African-American patient. So what that means is that taking an individual as a person and looking at what are the supporting structures that this patient needs to be able to succeed once they get back to the community, when they are discharged. The Black people is likely 30% less likely to have this, the physician is 30% less likely to have this patient-centered communication with an African-American patient compared to a white patient. So the way to resolve this is to bring this, let the medical student, the resident, people that are starting their career now, to be aware of this, to be cognizant of this situation so that they can address it. Because if you don't address it, it will continue. I still witness some of my colleagues that do this, I try to educate them more, but we can do a lot by making sure the new doctors that are coming up are aware of these biases. Now, also, Black people with mental health conditions, particularly schizophrenia and bipolar disorders and other psychosis, are more likely to be incarcerated than people of other races. And we know this is true. What they need is antipsychotic medication. They need treatment. However, they end up being locked up in a prison, in jail. And this is not right. So we need to be able to be aware of this so that for those that work in those situations, they can make sure that those patients receive the mental health care that is needed. Next. Now, I would like to talk about some recent events that occurred. We all know Chesley Chris, that she's a former Miss USA in 2019, I believe. She's a lawyer and she committed suicide recently by jumping from the story, I think from the 29th floor. It's so unfortunate. Now, why I'm bringing this up is this. When this happened, I was talking to some of my colleagues and there was this perception that, oh, what happened to her? She's Black. She is successful. She's rich. Miss USA. Why would she kill herself? So there's this perception that for the Black community, if you are rich, if you are famous, you are above mental health. You can have mental health issues. And which also means that the thinking is that once you are Black, you are poor, you are homeless, then you are more likely to have mental illness. So it's the bias. So sometimes we might say a Black man, a Black woman that is successful, we should not always think as medical students that they cannot have an underlying mental health. So that is the point in this. They can be going through issues, they can be going through struggles. Their mental health might be compromised irrespective of their status, because a Black man that is poor, that is homeless, is afflicted has mental health. So a Black man or Black woman that is rich, that is famous, cannot have mental health issues. No, we need to get rid of that thinking inside of us. Next. We know Regina King's son. He died of suicide. He's a young guy, promising, very stuff. So it's so just when this happened, a lot of the community, they're like, oh, what happened? Our mom is famous. Our mom is this, our mom is that. As if you're a Black man and you're successful, you are above mental health. No, that is another misconception, that it's only that if you are Black and you are rich, you cannot have mental illness. So in our practice, in our learning, in our training, we should be aware of the fact that Black people, whether poor, rich, famous, not famous, homeless, have home, we all deal with mental illness. Now, suicide rate among Black youth has doubled since 2014, and 12 out of every 100,000 Black people between 18 to 24 years died by suicide in 2020. Black young people are at more risk of depression, anxiety, and stress due to pandemic and also due to the spotlight on police violence against Black people. So we need to be aware of this fact. Next. Now, I would like to talk about substance abuse within the Black community. Now, the rate of illicit drug use slightly higher in African Americans than the national average. However, the rate of alcohol use is slightly lower than the national average, including heavy drinking and binge drinking. Now, what am I trying to say here? In the 1980s, when there is this cocaine epidemic among the African American, among the Black community, they were labeled as cocaine addicts. They were called addicts. Even though they had cocaine problem, it was not recognized in the society as a substance use problem. They were labeled as addicts. However, recently, when we now have the opioid epidemics, which affects more Caucasian, more white people than Blacks, it was labeled, they were not labeled addicts, it was called opioid use disorder. Actually, which is the right thing to do because it is a substance use disorder. But when it occurred, when the cocaine epidemic was more pronounced within the Black community, they were unjustly labeled as addicts. And when the opioid epidemic came up and it's more in the white people, they were labeled as substance use disorder. So you could see the bias. And the African American community, the Black community, they are aware of this. They talk about this. They're like, oh, during that time, they call them addicts. Now they don't call the white folks addicts. So that is why medical students should be aware of this distrust that a Black patient that comes to you, that you encounter, irrespective of your specialty later on in life, there's this mistrust, there's this distrust because they feel a great injustice has been done on them, which is the fact. So, but the more we are more aware of this in our daily medical practice, the more we become sensitive to this, and the more we can address this issue. And also, there's need to screen for many mental conditions, especially depression and anxiety. Next. Now, I would like to focus more on the tools, the solutions, the things that could be done going forward. Now, technology and therapy. With the COVID-19 situation, telepsychiatry has been on the increase. So access to psychiatrists has been, telepsychiatry has helped to bridge the gap that majority don't have access. The majority of people that didn't have access to see a psychiatrist, telepsychiatry has been helping. So telepsych is a powerful tool that has allowed psychiatrists and other licensed therapists to reach more patients, especially as the demand surges due to the pandemic. Now, as psychiatrists, we are responsible for dealing with the next week of this pandemic, the traumatic response of COVID-19. Now, we're still dealing with COVID-19, but later on, in the next few years, we'll be dealing with the traumatic response as a result of this COVID-19 once everything is under control, and the effect of isolation, unemployment, grief, it will place the already vulnerable population, which is the Black community, at risk for greater loss. So we need to be aware of this, and that is why telepsychiatric services, we try to address this, and there's something by the side about Nick the Rapper, which said, seeing a therapist, $100 per hour, telling myself it be like that, sometimes free. So what that means is, what it's trying to say is that trying to pay for it, the access to it. Next. Now, in the past, so this is technology and therapy using social media. In the past, compared to recent shows, whenever a patient, whenever an actor needs a mental health care within like maybe a show or a movie, it's usually the white population. It never involved the African-American, the Black community. But I think with social media, with time, with more awareness, some of the shows are actually talking more about the significance of mental health and therapy in their shows, and involving more people in the Black community, which are examples of the ones that I showed. The first one is the Dave Show, whereby his hype man has bipolar disorder in real life. And I think in one of the episodes, he was having lots of energy, and they felt that he was just rapping or talking fast. Actually, he was having a manic episode. But the fact that this is being brought up, it leads to the stigmatization of this mental illness among the Black community. So it is becoming more acceptable within the Black people that it is okay if you have a mental illness and you talk about it. There's nothing bad in it. There's nothing bad in going to see a therapist to talk about life issues. So these kind of shows have been having positive impact in the lives of the Black community. The next one is the Grand Crew, and it is a show whereby single friends are talking about Black men going for therapy, and, which is good, so that when people watch it, they know, oh, there's no problem if I'm a Black man for me to go and see this lady to talk about my life, to talk about my experience. And the other show showed another African-American lady going to talk to a therapist about it, and also the one on that side. So all these shows, as they've had a positive impact in the lives of people. In the past, it used to be white folks are going for therapy, and it looks as if these are not being provided to the Black community. But once we start seeing shows showing Black people going for therapy, it helps to let the Black community to believe in the fact that, well, they can seek treatment by going to see a mental health professional to address their needs. Next. Now, technology and therapy when it comes to mental health in particular. So there are this is particular for medical students, residents, and attendings as a whole. There are a lot of mental health apps that has been created to help people, the minority, the Black community, to access the doctors or the clinicians that they feel comfortable with. We know due to this distrust, some people still don't trust going to see maybe a white therapist or a white psychiatrist, and we have to be cognizant of that, and we have to try to help those people as well. So like the health, one of them is Health in Who, it connects to a Black doctor. So with that, a Black patient will likely feel more comfortable to talk about his or her issues to Black doctors. And we are supposed, as medical students, as residents, as attendees, so if we notice that this Black patient has this issue, they don't trust, there's this mistrust, we can inform them about this app so that they can connect to Black doctors that will help them in their mental health care. There is another one called Shine, and and it's the meditation-based app that helps with that. There is one called Ayana, and this connects a licensed therapist based on background. So if a Black patient wants to see a Black woman from Detroit, it can use this app to really, really narrow down. Let's say the patient feels more comfortable in a Black person from New York or from New Jersey or from California. It will help channel that patient to see the right person. So because they may not have this choice to see just anyone. They might not be comfortable to talk about their mental health care with anybody. So that app helps with that. Then the next one is Mind of the Culture, which is the faith-based therapy, and also the Safe Place. Now, the Safe Place is it helps with self-assessment and self-care tips. We need to be involved. We go through stress. We go through situations in life, and we need to talk as well. So the Safe Place helps with that. So talking to our patients, exposing them to this, giving them information about these apps, it helps a lot in their mental health care. Now, next. Now, why talking about mental health within the Black community? The biopsychosocial model is very important. These have been talked about by the previous speaker, and I will just highlight them. So a lot of things go into the health of a patient, especially the minority, the Black people. And so if you are a GI physician, a surgeon, OB/GYN, whatever you are, whatever subspecialty, the social history of the patient is very important. You cannot underestimate that, because it goes a long way to affect how the patient will take their health serious. So the education of the patient, the occupation, any underlying substance use, the living situation, the support system, all this can help elucidate any underlying stressors that are contributing to the patient presentation. Now, consider not only a psychiatric patient, but to all patients. So it's important when we say patient in our medical profession to always look into the social history, not just the actual presenting complaint that they came to the hospital for, but to look at what are the other factors that are affecting this patient that might be contributing to this patient presenting complaint, especially in the Black community that are already disadvantaged. Next. Now, earlier I talked about trauma. I talked about trauma-informed therapy, and I will just quickly gloss through it. It talks about it deals with safety, choice, collaboration, trustworthiness, and empowerment. And another safety, that means ensuring physical and emotional safety by having common areas are welcoming and privacy is respected. Choice. Individual has choice and control, and individuals are provided a clear and appropriate message about their rights and responsibility. Collaboration, making decisions with the individual and sharing power. Individuals are provided a significant role in planning and evaluating services. Task clarity and trustworthiness. Task clarity, consistency, and interpersonal boundaries. Being respectful and observing professional boundaries and ensuring professional boundaries are maintained. And also empowerment, prioritizing empowerment and skill building, providing an environment that allows individuals to feel validated and affirmed with each and every contact at the agency. Now, next. Now, practical applications. This is the last slide, I believe. So just to round up, there are practical applications that patients that we see within for whatever thing there is need to address and to screen for depression, be it pregnant, OB/GYN, or surgical patient. There is need to address substance abuse, which is common. There is also need to drive into the social history and also to empower this patient by providing them resources to help with their mental health care. Thank you.
Thank you, Dr. Olukatibi, for that wonderful talk. As you were speaking, it made me actually think back to a book signing I went to many years ago, where the book was called Black Pain. It Just Looks Like We're Not Hurting, by Terry Williams. And you really covered a lot of the points that she had covered in that book. I do see a question from the audience. We'll take maybe just one question because we're definitely over time now. From Kelsey Engelman. It says, Kelsey Engelman, an MD applicant. So not just med students and faculty, we also have future doctors on the line also. American models of therapy have been critiqued as highly Eurocentric. How can we expand this to include Afrocentric models to better deliver culturally sensitive care to racial and ethnic groups? And she also says, additionally, it has been stated that traditional research methods have been used to uphold hegemonic power structures. How does community-engaged research differ from traditional research methods in mental health? And how can this provide clinicians with valuable insights? So two-part question here. So the Afrocentric models of care was the first part.
Okay, so just to address that, I think this will include studying different ethnic group within the Black community, looking at the support group, looking at what they believe in. For example, there are some community that are much more faith-based, recognizing that and using the pastors, the imams, the religious leaders to address that. For example, I'm a Nigerian, so within the Nigerian community during the COVID-19 vaccine, a lot of people in my church did not want to get the vaccine, did not want to take the vaccine, but they listened to me. The pastor reached out to me. I spoke to the church, and they saw that I speak the language. I am part of them. They believed me. I showed them my COVID vaccine booster and everything. And within 2 weeks, more than half, of course, it is a Nigerian church, so we are all Blacks. So more than half of the whole church went to get their vaccine because I was able to talk to the church. Now, they were never going to do it, but they just believed that, oh, if I did it, then that means it's fine. I mean, I can't come to America to come and die, you know? I won't leave my country, come here and die. And so we have to be cognizant about what is peculiar about whatever group and address it and try to address. That is the way. Yes, it's true. We can't use the European model because it might not work. We need to understand what population group that you are talking about, that you are working with, and try to look at what do they believe in, what brings them together, and use that as a tool to address whatever healthcare that you want to address within them. So what's the second question? I forgot.
I'll summarize it. Basically, the value and the difference in doing community engaged research versus traditional research. Kelsey was commenting that the traditional research is formed in a way that it upholds hegemonic power structures. So should we be transitioning to a more community-based type of research?
Well, it depends. I don't have a clear-cut answer to that, to be honest. It depends, but depending on which study we are talking about, we could use the traditional research or a community-based research. For example, as I said, just like the example for my church, if you want to do any study in my church and you don't go to someone like me, nobody's going to listen to you. So you need to get someone that they are much more comfortable, but that will be a very small study. Now, if we talk about like the COVID-19 vaccine studies, that is a much more bigger one. And I believe a traditional method involving different kinds of people would be much more appropriate. But if it is something within a smaller group, I think we should use a community-based approach to address that.
Yeah, absolutely. I think one of the ideas to keep in mind when we think about the various cultures in America and around the world. And when you're seeing a patient who may be from what you think of as a particular country, religion, or what have you, always keeping in mind that everybody's culture can be very personal.
Yeah.
And so just because we're from the same place or from the same, whatever it is, part of town or same religion, we might have a very different culture. And you have to really, I know some of our speakers have commented the importance of the individuality, seeing each patient as a, almost like a universe in themselves, and not just to make assumptions about what people are or what they believe just based on what you might think about their culture. So thank you very much for that, those great questions. We'll move on now to our keynote speaker. Dr. Ashanda St. Jean is a graduate of the Sophie Davis School of Biomedical Education and CUNY Medical School. She later received her doctorate in medicine from New York Medical College. She completed her residency training at Danbury Hospital, Yale New Haven affiliate in Danbury, Connecticut. She is board certified OBGYN physician with a wealth of experience in New York City, focused on the delivery of quality care to underrepresented minority women. Her life's work has been devoted to the excellence in healthcare delivery via patient-centered comprehensive care, which is inclusive of mental health and well-being. She is committed to women's health issues, most importantly, focusing on racial disparities, health equity and inclusion, maternal health safety, maternal health policy and access, the role of telemedicine platforms in maternal health, and teen pregnancy. Dr. St. Jean is the chair of OBGYN at Health Alliance Hospitals, part of the WMC Health Network, and associate professor in the Department of OBGYN at New York Medical College. She previously worked at Columbia University Medical Center, New York Presbyterian Hospital for 14 years, where she was the director of outpatient OBGYN services for the Ambulatory Care Network. She is a champion for patient advocacy, midwifery, and doula care, breastfeeding, lactation awareness, diversity, equity, and inclusion. Please welcome Dr. St. Jean.
Thank you so much, Dr. Etienne, for having me. Okay, so I just want to express how honored I am to be a part of this conference. And I want to discuss, what is prevalent and what's happening in our country and our world right now. And that's the impact of COVID-19 on pregnant women, specifically Black and Indigenous people of color, but also how we together can alter the course. I don't have any disclosures and I have no conflicts of interest. So let's just start. Hold on one second. Let me just make this a little bit this way. Okay, perfect. Let's just review the basics of COVID-19. It is a virus that may cause severe acute respiratory syndrome, and the severity of the disease can vary, but includes mild, moderate, and severe symptoms. And mild symptoms compose of fever, malaise, cough, upper respiratory symptoms, but they often do not require hospitalization. And then there's moderate disease, but in the presence of pre-existing comorbidities, that can contribute to the need for hospitalization. And then we look at severe symptoms, and those include dyspnea, hypoxia, where there is an O2 saturation of less than 94% on room air, or the need for oxygenation or ventilation support. And those are symptoms that do require hospitalization. So as we kind of pivot in understanding what COVID is, I want to discuss in detail how COVID-19 affects women, and especially its impact on pregnancy, fertility, and lactation. Now, we must stress that pregnancy and recently pregnant women are at increased risk for severe illness when they are affected by COVID. And those severities of illness can cause hospitalization, ICU admission, mechanical ventilation, ventilator support in the terms of ECMO, and even ultimately death. So let us look at what the numbers look like here in the United States. And this data is collected by the CDC, and it's starting from January 22nd, 2020 through February 7th, 2022. So across the United States, there have been 171,428 cases of COVID-19 in pregnant people. Of those cases, 29,008 required hospitalization. And tragically, 273 resulted in the death of the patient. When we look at the timeline of the data, we see that there are certainly spikes that have occurred at certain time intervals throughout the year. If we look at this graph right here from the CDC, we can see that the largest spike occurred around November 21st, 2020, and that corresponds with the holiday of Thanksgiving. And through the end of the holiday season, that included Christmas and New Year's. And then we see another spike here in December of 2021. What this chart really shows is that holidays can be a time of super spreading because of increased traveling, but also family and friends coming together, and that also potentiates the exposure of COVID-19. So then we also want to look at, well, what kind of age groups are really infected by COVID while they're pregnant? And if we see here that we have the highest aggregate of cases that occur between the age groups of 25 to 29. Now, we understand that since this COVID pandemic has started, there has been a decrease in the birth rate across the United States. However, we know that the incidence of pregnancy in our highest level of reproductive years are between our 20s and our 40s. And so this correlates with kind of that high aggregate of reproductive women. Next, we want to look at race. So when we look at this kind of graph from the CDC, it appears that white non-Hispanic women are the most affected and have the highest number of cases of pregnant people. And it appears that Hispanic or Latino women are next, and then third would be Black or non-Hispanic women. But what we want to make sure that we understand is that this race ethnicity data was only available for 86.6% of patients. So that's roughly about 150,000 women. And we want to also make sure we note that Black patients make up less than 20% of overall number of pregnant women. And also, we want to also understand that Hispanic women were also largely affected by this COVID-19 pandemic. So then we want to also take a look at what were the cases of severity of illness that affected pregnant people, and we really want to kind of focus in home on is the high risk that occurs for pregnant women. So here we look at the number of cases of pregnant women that were admitted to the ICU, that required invasive ventilation, and ultimately required ECMO as well. So when we look at this meta-analysis that reviewed all studies between December 2019 and June of 2020, in total we had 77 cases were reviewed, and it included over 13,000 pregnant women and 83,000 non-pregnant women. And what it showed us is that these were the ultimate high risk factors for COVID in pregnant people. One was advanced maternal age, so that's an age greater than 35 years old, a higher BMI, chronic hypertension, and pre-existing diabetes. And what we saw was these were the results of maternal outcomes. So we have all-cause mortality, we have ICU admission and invasive ventilation. And then we look at fetal neonatal outcomes. And that we also have to remember when we look at the pregnant patient, we're looking at two people. We're looking at the mother and also the baby. And so there are risks to the baby as well. And those included preterm birth, stillbirth, cesarean delivery, and NICU admission. And here is another graph that further looks at pregnant women when we compare them to women of reproductive age with COVID. And we see that pregnant women have a far greater rate of ICU admission, invasive ventilation, and ECMO, and the need for ECMO. In addition, this study displays a marked increase in pregnancy complications for pregnant patients with COVID, and those include maternal death, preeclampsia, preterm birth, stillbirth, and NICU admission. I want to just kind of pivot for a second and talk about a case, because I know we have medical students in our audience, and I want to kind of bring forth a tangible clinical scenario. So I actually had a patient during, in the past 4 months, who was pregnant, who had a normal prenatal course. She had no existing comorbidities. She did not have a higher BMI. She did not have advanced maternal age. She actually was a social worker. And what happened is she was exposed to COVID by her spouse. Her spouse was active in the armed forces, and within 48 hours developed difficulty breathing and had to be hospitalized. Within 4 hours of her OB triage and labor and delivery suite, she was transferred to the ICU because her condition deteriorated. She actually remained in the ICU for over 10 days. She required stress dose steroids and nearly required ventilator support in early delivery. So we have to also remember when we learn about these different illnesses, we have to personalize these and kind of think of our patients and how we can provide patient-centered, patient-focused care that also addresses all their individual needs. And one of those, in addition to this, is mental health needs, because we have seen that there has been an increase in anxiety and depression during this COVID pandemic with our pregnant patients. Now let's talk about our fetal and neonatal outcomes. From a fetal perspective, the impact of COVID during pregnancy can be extensive, and outcomes can include vertical transmission. Now this may occur, but it is very uncommon. But also there is the increased risk of preterm birth, increased risk of pregnancy complications, and those include not only preeclampsia, but coagulopathy and also stillborn. And then lastly, we talk about the increased risk of NICU admission. Now we have some really promising data that just was actually released. We have the latest study that was published in JAMA in February of 2022, and it reveals that the presence of COVID-19 antibodies at 6 months of life for pregnant patients vaccinated during pregnancy. So what we're saying is newborns actually have had COVID-19 antibodies up to 6 months of life. And these are in pregnant patients who were vaccinated or who had natural COVID infection during their pregnancy. Now let's look at the timeline of how ACOG is our American College of Obstetrics and Gynecology, and how they developed this COVID-19 vaccination. Because we have to also remember in the beginning of this pandemic, and then also when we had the vaccine, there was a lot of apprehension of pregnant people getting the vaccination because there was concerns about the vaccine. And then also there's heightened anxiety being that they were pregnant. So in December 2020, the Pfizer vaccine was recommended. However, pregnant patients were excluded from the clinical trials, and it was only animal model data in pregnancy. And so again, there was no safety signals that were indicated. And then we kind of pivot to December 13th, 2020, where ACOG recommends pregnant people have access to COVID-19 vaccines. And ACOG recommends risk-benefit conversations with the clinician. And again, that's key. You want to have those discussions with your patients. You want your patients to be able to share their lived experience, but also there should be the option and the potential of shared decision-making. Okay, and then we go to December 21st, where then the Moderna vaccine was recommended, and also ACOG practice advisory was revised to actually recommend both mRNA vaccines. And then we go to January 2021, so about a year ago, where ACOG receives reports of pregnant patients being denied access to COVID-19 vaccines, and they develop recommendations for all of their providers and for the world overall. So as we kind of look at this year that we just passed, we have in January of 2021, the CDC begins reporting numbers of people enrolled in Be Safe after vaccine, and we'll talk a little bit about that later. And then in February, we actually came out with a lead statement saying maternal immunization task force and partners urge that COVID-19 vaccine be available to pregnant individuals. So that was a very, very important time because we are able to help our patients who are certainly at risk for severe disease, to kind of protect them during their birthing journey, their pregnancy journey, and ultimately their the birth of their child. And so we kind of look and we want to pivot on to March, where we actually see that there's the first safety data from VSafe, the pregnancy registry reported. And this is really, really helpful because, again, patients wanted to see that data because, again, there was heightened concern. And as talked about before with our other speakers today, there is sometimes a mistrust with marginalized communities, with communities of color, with underrepresented minorities about the medical system in whole because of past events. So let's just talk about how the COVID-19 vaccine works. The genetic material instructs your body to make a protein that is part of the virus that causes COVID-19. The protein tricks your immune system into thinking it sees the COVID-19 virus. Your immune system then makes antibodies and other defenses. And if a person is later exposed to actual COVID-19, the body is now able to recognize the virus and make antibodies to fight it. So we're going to briefly just go over the different types of vaccines, right? So right now in the United States, we have two different types of vaccines. So two different groups of vaccines that we offer and that are approved by the FDA. We have under the mRNA vaccines, we have Pfizer and we have Moderna. And then under the adenovirus vector vaccines, we have the Johnson & Johnson. So let's first talk about the mRNA vaccines. So the mRNA vaccines consist of messenger RNA that is encapsulated by a lipid nanoparticle for delivery into the host cells. All right, it utilizes the body's own cells to generate the coronavirus spike protein that stimulates immune cells to create antibodies against COVID-19. So first, we need to talk about what are the common myths that patients think and how we can dispel those myths and kind of defy the misinformation that is out there. Number one, it is not a live virus vaccine. So again, we know that we don't give live virus vaccines in pregnancy. So because this is not a live virus vaccine, it can be administered during pregnancy. It is no adjuvant. Okay, so that means that there is no substance that enhances the body's immune response to the antigen. All right, it does not alter human DNA. It does not enter the nucleus and does not cause any genetic changes. Now, again, we as clinicians, we have an opportunity to educate our patients. And it's important that we tell them these very specific things because, again, because there's a world of misinformation, we want to make sure that our patients are properly supported and provided the best education so that they can make the best decision for themselves and for their families, that one that will promote their health. So here, this is a schematic an illustration that shows how the mRNA vaccine works. And I put this in mostly for our medical students because I know this is always a hot topic. And then you always want to kind of apply, your basic science knowledge to what is going on. So we'll just quickly review it. Messenger RNA vaccines teach our cells how to make a protein that will trigger an immune response in our bodies. The mRNA will enter the muscle cells and produce a spike protein. The spike protein is found on the surface of the virus that causes COVID-19. After the protein piece is made, our cells break down the mRNA and remove it. Our cells display the spike protein piece on the surface, and our immune system then recognizes that protein doesn't belong there, and it triggers an immune response, and thus producing antibodies and active immune cells to fight off what it thinks is an infection. Now, like all vaccines, mRNA vaccines benefit people who get vaccinated by giving them protection against diseases like COVID without risking the potential serious consequences of getting sick. So this is something that we always have to reinforce with our patients, because again, there is that skepticism, there is that mistrust, and again, rightfully so because of the history. Again, our speakers spoke about it, but again, we have this opportunity to turn the page and create a brighter future for our patients by giving them the education and actually having this conversation and shared decision-making with our patients. So next, let's talk about the Johnson & Johnson vaccine. So this is a different category. It's an adenovirus vector vaccine. It's a monovalent vaccine. It's composed of recombinant, replication incompetent human adenovirus type 26 vector. Now that's a mouthful, but again, it's important that you understand kind of the background of this. So this is where your basic sciences apply, okay? It encodes stabilized forms of SARS-CoV-2 spike protein, and it is cleared from the tissue shortly following injection. And adeno 26 vector cannot be replicated, okay? It is important, again, that we stress to our patients that it's not a live virus. It does not contain preservatives, and it does not replicate in the cells. Now, we want to talk about the COVID vaccine efficacy. All current available COVID-19 vaccines have demonstrated high efficacy. The evidence suggests fully vaccinated people are less likely to have asymptomatic infection or transmit infection to others. And those with up-to-date vaccinations are less likely to experience severe illness and serious adverse outcomes. And again, this is what we're seeing now as we're arriving at more people being vaccinated. And so we're having the decrease in our hospitalizations, but it doesn't completely rule out severe disease. So again, we also want our patients to be healthy, and then also to promote various practices, social distancing, mask wearing, and usage of hand sanitizers. Again, COVID-19 vaccines are effective. They can keep you, I apologize. They can keep you from getting and spreading the COVID-19 virus and can prevent you from serious illness that you can get from COVID-19. And we talked about those things. So that's ICU admission, hospitalization, or the need for ventilation support in terms of ECMO or any invasive ventilation. So also we know that getting vaccinated may also protect people around you, especially people at increased risk for severe illness. So we all live with people, most of us, and so we want to be respectful of the people that we live around, especially if they have compromised health or comorbidities that would put them at increased risk for COVID-19. So let's talk about the COVID-19 vaccine efficacy during pregnancy. So here we have a study that was published, and we had two cohorts. We had a cohort of vaccinated pregnant people and a cohort of unvaccinated pregnant people, and both with the same number of patients, 7,530. And what we see here is that vaccination with mRNA COVID-19 vaccines actually lowered the risk of infection amongst pregnant people. So here we see this is unvaccinated, here's vaccinated, and we see that the incidence is rather lower, okay? So then let's just talk about what are the side effects. So, again, there's a lot of reporting of side effects. And so we want to be respectful and hear what people have experienced, all right? So we see that with Moderna and with Pfizer and with Johnson & Johnson, right? We have injection site reactions. The highest was amongst Moderna. All right, and then fatigue, the highest again was with Moderna as well. With chills, we had the highest with Moderna. Muscle pain, the highest was with Moderna. Joint pain, Moderna, and then also with headaches, Moderna. All right. So I just want to kind of provide the actual statement from ACOG. And so ACOG does strongly recommend that all eligible persons greater than 12 years old, including pregnant and lactating individuals, receive the COVID-19 vaccine or vaccine series. And any of the current authorized COVID-19 vaccines can be administered to people, to pregnant, recently pregnant, or lactating people. Again, we want to again stress that COVID vaccination during pregnancy is recommended. However, the mRNA COVID-19 vaccines are preferred over the Johnson & Johnson. And again, ACOG recommends that pregnant and recently pregnant people up to 6 weeks postpartum receive a booster of COVID-19 vaccine following the completion of their initial COVID-19 vaccine or vaccination series. So let's talk about vaccine safety in pregnancy. Studies in animals receiving Moderna, Pfizer, or Johnson & Johnson before or during pregnancy found no safety concerns in pregnant animals or their babies. Number two, vaccines that use the same viral vector have been given to pregnant people in all trimesters of pregnancy, including a large-scale Ebola vaccination trial. No adverse pregnancy-related outcomes, including adverse outcomes affecting the babies, were associated with these vaccinations in these trials. And none of the COVID-19 vaccines contain live virus that cause COVID-19. So a COVID-19 vaccine cannot make anyone sick with COVID-19, including pregnant people or their babies. Again, it's important to know and address the fears and the concerns of our patients. And one of the other concerns is fertility. And again, there are no claims linking COVID-19 vaccines to infertility. So that is completely and utterly unfounded, and there's no scientific evidence to support it. And also, given the mechanism of action, the safety profile of the mRNA vaccines in non-pregnant individuals could not be a cause of infertility. So again, it is recommended for all patients who are considering future pregnancies, but it will not cause any infertility. And again, here, there have been two big studies I want to talk about. One prospective cohort study of couples trying to conceive, and it found no meaningful association between COVID-19 vaccine in either partner, okay? And then the second study was a study out of Mount Sinai that investigated fertility outcomes after COVID-19 vaccination, including egg quality, embryo quality, and development pregnancy rates and early miscarriage. And the study showed no difference in rates of adverse outcomes in vaccinated compared to unvaccinated patients. So I just want to again pivot and talk about lactation as well, because again, there have been so many current concerns and misinformation surrounding the vaccination with pregnancy, with fertility, but also with lactation. And so again, this vaccination is recommended by ACOG to be given to lactating individuals. And there is no need to avoid initiation or discontinuation of breastfeeding when you receive the vaccination. And the current data demonstrates that lactating women who receive the mRNA vaccine have antibodies in their breast milk, suggesting a potential protective effect against infection in the infant, although the degree of the clinical benefit is not yet known. Okay, so again, we want to be clear on those things because we want to provide our patients with, with cutting edge information, with knowledge and education, because this will inspire them to make the decision that is right for them and their family, but one that will promote their health. So I just want to touch on this very briefly, but there is a vaccine monitoring system. It's called the Vaccine Adverse Event Reporting System. It collects and analyzes reports of adverse events that happen after vaccination. Anyone can submit a report. That could be parents, could be patients, could be healthcare professionals, and it's closely monitored by the FDA and the CDC. Now let's talk about what has been the impact of COVID-19 on pregnant people. So it has caused increased maternal mental health issues, including anxiety and depression. There has been an increase in domestic violence. There has been a decrease in prenatal care visits and overall prenatal care. There has been struggles in working families with the increase in childcare demands. And there's also been the income loss or unemployment that has happened to our patients. We also kind of want to look at what are the barriers that have been in place that have hindered pregnant people from seeking care during this pandemic. Well, number one, initially there was the elevation of healthcare in whole to a telemedicine platform. But also we have to understand that some patients may lack smart devices, broadband or Wi-Fi, or even cellular data. There's also been transportation needs. There's been a fear to use public transportation. There's been a loss of income, thus affecting the ability to cover the cost of transportation. There is the lack of childcare or remote learning, homeschooling. There's unemployment or lacking of medical health insurance coverage. There's been also anxiety and fear of medical facilities and offices. So we have a lot of patients who have, are quite reluctant to seek medical care because their fear of getting sick or being exposed to anyone who's sick. And then also we have patients who have COVID symptoms, who just basically cannot leave their home, or they're in quarantine for exposure or even with active symptoms. And then we talk about the impact of COVID on Black pregnant patients. So when we look at pregnant patients, again, only about a third of pregnant patients are vaccinated. And of that third, only 15% of Black pregnant patients are vaccinated. So again, this is something that we want to concentrate our efforts on. We want to promote vaccine confidence and also address vaccine hesitancy. But we need to also talk about the impact of COVID in the Black community as a whole. Greater than a third of Black and Hispanic New Yorkers were infected in the initial wave of COVID-19. That's twice the infection rate than white New Yorkers. 39% of COVID-related deaths have happened amongst Black people, but Black people only make up 15% of the population. So given this, what are the other things that impact minorities and underrepresented minorities as Black people or Black and Indigenous people of color? Well, we have to talk about the social determinants of health. And we have to talk about healthcare access as a whole. We have to talk about the lack of insurance coverage, unstable housing, food insecurity, lack of transportation, income, education. Acknowledging the social determinants of health that impact healthcare in general and the ability to receive it, that's how we make an impact with our patients. That's how we affect change. And so that's what we want to do, is kind of, with our medical students who are listening today, you are the future. And so we want you to kind of provide care to our patients as you would provide care to your own self, to your families, to your loved ones. We want to kind of afford our patients conscious healthcare delivery. So we want to be conscious of what plights our patients, and we want to address it appropriately with respectful care. So how do we build vaccine confidence? We know that these vaccines are new, but how do we alter the course? How do we affect change? How do we make change? How can we combat COVID, especially for the communities that have been so affected and so devastated? Well, I think that we have to have this kind of circle of safety for our patients where we listen. It's very important to listen. They want someone to validate their feelings. They want to be heard. They want to share their lived experience. So we want to listen. And then also we want to share our experience. Sometimes our patients want to know, are we vaccinated? So there's opportunities for us to share. And then we want to talk about educating, and we want to give them the information so that they can make the appropriate decision, one that is with educational knowledge that will support their healthcare needs. And then again, we want to support our patients. And again, always we want to do this in a respectful posture. And hopefully at the end of this, we can vaccinate. But again, the importance is letting our patients know that when they are with us, they're within a circle of safety. So let us talk about some of the myths and versus the facts that contribute to us building this COVID-19 vaccine confidence. So one of the myths is it was rushed, it isn't safe. So researchers took no safety shortcuts. Large studies show that the vaccine is safe. Another myth is it changes your DNA. It's impossible for a vaccine to change your DNA. Next one is it can give you COVID-19. It doesn't have egg protein. Well, it doesn't give you COVID-19. And also it contains egg protein. And again, this is very, very important, especially for our patients who have allergies, food allergies, so we want to make sure that these vaccines are safe and not going to potentially put them at harm. So we want them to know they don't have egg protein and can be given to patients with egg allergies. And also that it causes side effects. So again, it gives you COVID-19 or it may cause side effects. So we want to make sure that we instill that these patients, that it doesn't do that. And then also it makes women infertile. And there is no evidence that the vaccine causes infertility. So the discussion of the myths and the misinformation that have flooded all pathways of media and social media, it's important to recognize that. And again, listen to our patients, hear them out, and see how we can affect change for that. The next we want to talk about when we talk about vaccine confidence is community. We have the opportunity to be part of that community, the community of trust with our patients. So when we look at community, there's three things that really focus on community: understanding, trust, and sharing. We want to do community engagement and proceed and promote understanding. We want to partner with faith-based organizations and leaders. We want to also impact social media. There's a lot of misinformation out there, and we want to make sure our patients get the best information. We want to also share our personal stories and our testimonies and allow our patients to do the same. And we also want to provide culturally sensitive themes and also have a cultural presence, but also be culturally competent and provide culturally congruent care. So as we talk about what we can really do, right? What can we do as clinicians, as healthcare providers? What can we do to impact change? We can be generous of time and spirit. We can provide judgment-free, respectful care. We can lead with empathy, compassion, humility, thoughtfulness, understanding, and above all, grace. So as I talked about the patient before who was admitted into the ICU, she was admitted at another facility, a tertiary care center in the ICU. But once I found out that she was in the ICU, and I found out immediately when she was admitted, I spoke to her daily. And just that call from her doctor, that was so comforting for her. But not only that, when the other doctors were, again, trying to provide a treatment care plan that would be better for her and the baby, again, she had some questions and felt that they were not appropriately addressed or heard. So I participated in daily rounds with the ICU team on FaceTime so that I could provide that comfort the patient needed, but also a further clarity of understanding of the medical process. We have to understand our patients are at a critical time where they may need that extra layer of support, and we can provide that. And sometimes it's through different modalities. It may be creative solutions, but I want you to know, especially our medical students who are listening, you can do it. And you can impact that change to your patient, and that can change their life. Again, you have the opportunity to give life-changing care. And this is one of the things I want you to focus on. Now, there are also strategies that have been put forth from the CDC that will promote healthcare equity and the use of data-driven approaches, fostering meaningful engagement with community institutions and diversity leaders, leading with a culturally responsive outreach, and reducing stigma, including stigma associated with race and ethnicity. So again, I say to you, how can we install vaccine confidence? Well, we can amplify the voice of the patient's lived experience. We can also normalize hearing patient stories, uncovering that next layer of understanding, and giving power to patient testimonies. And we can provide education that defies and helps promote and combat social determinants of health, that promote resources, but also magnify respectful, culturally competent care that promotes both health and mental well-being. I would like to leave you with a quote that I always think about, and especially it is apropos for Black History Month. And this is a quote from Dr. Martin Luther King Jr. Make a career of humanity. Commit yourself to the noble structure for equal rights. You will make a greater person of yourself, a greater nation of your country, and a finer world to live in. So I would like to thank ACOG, the New York City Department of Health, New York Medical College, Westchester Medical Center Health Network, and Dr. Tedra Hardy, our chair of Department of OBGYN. Thank you for this opportunity.
All right, wonderful. Thank you so much, Dr. St. Jean, for that remarkable talk. I really liked your focus on humanism as such a really, I think when we focus on that, I think it knocks down so many barriers, and that's the commonality amongst all of us. And I really appreciated your circle of trust, or circle of safety, the safety circle. I think that was a really awesome idea to have something like that. And our patients are seeking safety when they come to our offices, and the idea of validation, validating our patients' concerns. I think a lot of the talk show hosts, I know one in particular on her retirement said, Oprah Winfrey, she said what made her show so popular was that when guests came on the show, she validated their many concerns and what they were going through when others had doubted them. So thank you very much for really bringing it all together in a nice package, and also giving the students a lot of education on COVID. Now they're going to do well on the next micro exam. I guess they won't have it till next year. Okay, great. Any question? I don't see any questions in the audience. So Dr. St. Jean, thank you once again for that wonderful talk and spending this time with us. This brings us to the end of our program. So I do want to thank all of our guests for staying with us for, I would call this the long haul, pun intended, for this conference. Thanks to all of our speakers for these wonderful talks. I'll just remind you, Dr. Halpern opened up with a historical perspective and provided some new information regarding the U.S. Public Health Service syphilis study on the men of Tuskegee, Alabama. And whenever I refer to that study, I always refer to it in that way because I am a visiting scholar at Tuskegee, and they do not like it being called the Tuskegee experiment because they said it was not our experiment. It was the U.S. Public Health Service's experiment. And what I took away from the talk from Dr. Halpern, one of the key points I found was the experiment was wrong then, it is wrong today, and it will still be wrong tomorrow. Regardless of what additional little ideas people dig up from relics, it is still wrong. Dr. Gardner did a deep dive, taking us from the Middle Passage to the present to show us the many sources of health inequities, including the role of medical education has had in contributing to these inequities, and what role medical education has in contributing to removing and eliminating these inequities. So they're very, very important points. Dr. John gave a very compelling argument showing us the role that policy can have in eliminating health disparities, particularly using the data from kidney transplants. Dr. Olukatibi, we just heard from him, shed a great deal of light regarding the myths about mental health in the Black community, covered trauma-informed care. And of course, our keynote speaker, Dr. Saint-Jean, who stressed the importance of humanism in medicine and the importance of validating our patients to help improve their health and to restore any lost trust that they might have in the healthcare system. All very, very important points. All different specialists took this question and these issues from different angles, but brought us all to the same exact place, which is the importance and the high value of humanism, and that it's not just, and there are many different ways to actually tackle the beast and the horrible things that are causing these health inequities. Thanks again to everyone who had a role in making this event a success. I named them all at the very beginning so that I don't forget anyone at the end. Also, thanks to the WMC Health Network for partnering with us on this very important event. I do urge you all to mark your calendars for March 23rd for our Women's History Month event. The theme for that conference will be Knocking Down Barriers, Women in Healthcare and Academic Leadership. So that concludes our program. Thank you all once again for spending your afternoon with us, and I guess now let's say your early evening. Some of you are probably having dinner already, but this concludes our program. Thank you once again. Have a good night.